Um, Good afternoon, everyone. My name is Peter Pappas, and I'm chair of the MSG Scientific Committee, and I'll be moderating part of this session this afternoon. Luis Ostrowski-Zeichner will be moderating the abstract presentations, but I'll be starting off. And so each of you should have an agenda, and I will assure you that we'll be sticking to this agenda. It's tight. There are no breaks, and we just kind of want to go through and keep it as tight as possible so that we are done at 4:30 Eastern time as planned. Just a couple of words as background, and then we'll get into this. The development of post-COVID invasive fungal infections has been something that's been of great interest since we first recognized COVID. And I think the parallels between, for instance, Aspergillus complicating COVID and that which occurs in influenza infections was really too obvious to ignore. And so much of the focus of COVID-associated fungal infections has really focused on Aspergillus specifically, and rightly so. Although there's still controversy as to what it means, how you define it, what the rates really are, and I think that our speakers are going to get into that. Especially Tom Patterson, who's an expert in this, will provide us with some really interesting and some of the latest insights into this. But we've also got some terrific speakers that are going to be shedding some light on COVID-associated mucormycosis. Dr. Chakrabarti from India, right in the midst of just a massive outbreak of mucormycosis associated with or following COVID. And then Ibrahim from UCLA Harbor is going to talk to us about some potential genetic predispositions to this condition for sure. And then we'd also like to welcome sort of a new investigator on the scene. Jeremy Walker from UAB is going to talk about the possible connection between COVID and invasive cryptococcal disease, something that has been observed in areas where cryptococcal disease is higher incidence, perhaps. And he's going to share with you some anecdotal experience that we've had here and at other institutions, generally in the Southeast. G.R. Thompson from UC Davis will be talking about their experience and the published experience with endemic mycosis following COVID. And then finally, Megan Lyman will be sharing with you some more global experience on invasive Candida infections associated with COVID. So we have many of the major fungal pathogens that have been associated with COVID being covered today. I can assure you that each of these reviews is going to be up to date and insightful. The people that have agreed to do it, we're just so grateful for that, and really looking forward to their comments. So without further ado, I'd like to go and introduce our first speaker, Tom Chiller, who's chief of the Mycotics branch at CDC, is going to give us 20 minutes on kind of the CDC perspectives on this, how CDC looks at this, how they view it, initiatives that have occurred within the CDC. And with that, Tom, thanks again for agreeing to do this, and looking forward to your comments.
Thanks, Pete. Appreciate it. I want to just, before I start, make sure, do you guys see the appropriate screen?
Yeah, looks good.
Yes.
Excellent, because I have multiple screens here, as many of us do in this virtual era. So thanks, Pete, and thanks to the Mycosis Study Group. I'm thrilled and excited that you guys have put this all together in one shop, which is fantastic. We've been talking about, as you mentioned, fungal diseases and COVID for a while now. but it's great to see this line up. And I'm just going to be brief and really give maybe a few of our perspectives and an overview of some of the things that will be talked about today in much more detail by the experts. So again, I'm excited to sit back and listen as others address. Clearly, we've seen a lot on this in the news, and the fungal infections associated with COVID have hit all kinds of headlines, including changed an entire nomenclature to color schematics, which have been an interesting things for all of us in the infectious disease world, getting these fungi named different colors. That being said, I don't think we are going to continue to refer to them in this way, but it's been an interesting way to look at how the public is seeing these diseases. COVID-19, I wonder, has it really added another chapter to our understanding of fungal disease? People with severe COVID are particularly vulnerable. Fungal co-infections are reported with increasing frequency, associated with severe illness and death. Symptoms of some of these fungal diseases are similar to COVID-19. And we know physician and public awareness is more important than ever. But is that really a new chapter? And as you heard Pete mention, all of these similar concepts have come out with post Aspergillus in influenza. And so, as we mentioned, we sort of saw this coming, at least for Aspergillus. But what I think is different is it's not just Aspergillus with COVID. There are other diseases, in fact, many of the fungal diseases, if not all, that have some sort of association that we're still working out with COVID. And of course, we're going to hear about that in much more detail today. So I thought I would cover a couple of these just briefly, because you're going to hear much more about this from Tom Patterson next up. But we know about this invasive pulmonary aspergillosis as a complication of influenza. There was a lot of low awareness and actually infrequent testing. Similar ideas with what we now call Kappa, COVID-associated pulmonary aspergillosis. A lot of reports out of Western Europe, and really one of the most commonly, at least reported and associated COVID-19 fungal infections. And I'm sure Tom will cover this data, but just to say that clearly having an effect and having a burden on patients who have COVID and unfortunately get aspergillosis. A lot of unknowns that with all of these entities, especially here in the US about Kappa, what the impact on mortality versus simply a marker of COVID-19 severity, as most of these patients, not all, are in the ICU. What does this do for antifungal treatment and prophylaxis? And I know that we've been working with the mycosis study group to try to delve into this in much more detail across multiple centers, and I'm sure Tom will talk about that. Switching now to invasive candidiasis, which you'll hear from my colleague more about, Megan Lyman, later on in the afternoon. It's really not your typical candidemia associated with COVID. This is different. Liver disease, cancer, prior surgery are less common in the reported cases. ICU mechanical ventilation, central line steroids are more common. Admission to candidemia seems to be longer versus typically for non-COVID, and maybe inpatient mortality is higher. And this is some of the data that was published recently. Candida auris, the new kid on the block, maybe not so new anymore, increased dramatically during COVID. A brief blip down at the beginning when probably people were too busy to look for it. And then you can see, and Megan will cover this later, but we've seen it now. Candida auris spread to new parts of the US, outbreaks occurring in previously well-contained areas, unfortunately. Most transmission still in these longer-term care facilities, which, as we all know, were at the heart of COVID-19. but also outbreaks in acute care hospitals, and frequently in these COVID-19 units. And, again, potentially related to changes in routine infection control and prevention. We also unfortunately saw the first cases spreading down into other parts of the Americas, associated often with COVID-19, Brazil, Guatemala, Mexico, Peru, and then an outbreak and multiple outbreaks reported among COVID-19 patients in hospitals, one that we know from in Mexico. Switching gears to COVID-19 associated mucor. Again, we're going to hear more about this from our colleagues, but this really started the color schematic where this was named as the black fungus. We all know mucor is just a medical emergency, and certainly a concern in any patient who has it, but now we know a concern with current or recent COVID-19. We'll hear a lot more detail about the India cases, et cetera, but we're also seeing cases in the Americas. And I think it's going to be important to understand why we're seeing these cases. And I know we'll hear more about that, but it's not just an Indian phenomena. We have had multiple cases described in the Americas. You can see PAHO put out an epidemiological alert. This led to the report of actually quite a few cases, including recent clusters in Honduras. We've had cases reported in the US, and you can see in Brazil, Chile, and others. But clearly, there's always been a need for early diagnosis in this disease, and this has really shown us the importance of that. And then finally, talking a little bit about the endemic mycosis, we'll hear from Jeremy and George Thompson on this. But there is some evidence of valley fever co-infections, and I know George Thompson will cover this. Will be interesting to hear how he talks about this as a coincidence or a reactivation or other possibilities. I think described by our colleagues in Kern County as the triple threat, COVID-19, flu, and valley fever, being very hard to discern from each other. And they certainly were very concerned early on in the pandemic about these three coalescing, especially in that part of the country where Cocci is so prevalent. I think thankfully we've had a relatively low flu burden, as we all know, and I think we're hoping for another lower flu burden this year. There's also been other endemics, co-infections reported, histo in the Americas, unclear about some of the other endemic diseases. Certainly wider use of steroids and immunosuppressants we think would increase the risk of these symptomatic endemic mycoses. And then again, we'll hear from Jeremy about late reactivation of crypto and maybe its association with COVID-19. And so I'll just end with a couple, final thoughts in that whirlwind tour of COVID-19 and fungal infections. I think it's really important when we think of fungal epidemiology that generally it's local, not so much global. Now we can learn from local lessons and maybe apply them globally and certainly pay attention. But we all know that fungi, at least environmental fungi, are unequally distributed. And it really depends on the microbiome. We talk about microbiome in patients, but here I'm talking about the environmental microbiome, or maybe the soil microbiome, or the plant microbiome, where these fungi exist. And so really that local epidemiology is important. And I wish certainly in is this environmental microbiome study. And then for something like candidemia, where it's more of an auto infection, then of course we worry about the gut microbiome, or in the case of C. auris, the skin microbiome. And so I just think one of the things that we're thinking about certainly at the CDC is this phenomenon. And then finally, the public health messages. We know COVID-19 can become complicated by secondary invasive fungal infections. These infections are difficult to diagnose. We'll hear more about that today, and obviously associated with poor outcomes. And so our continued cry for more surveillance, some better diagnostic algorithms, better diagnostics in general, and education to healthcare providers. So think fungus saves lives, as you all know, is our motto. And Pete, thanks for letting me kick this off, and I look forward to a great afternoon of presentations.
Thank you, Tom. And let me ask you a couple of questions because we have a little extra time here. And so could you kind of explain in broad terms, what sort of surveillance can CDC do? Now, you've partnered with the MSG to get a sense of Kappa. What more can you do? What are what kind of tools does the CDC have at their disposal that can make statements about some of these other conditions? Is it completely dependent on reports that those of us in the outside world provide, or can you do something proactively? What are your thoughts on that?
Yeah, thanks, Pete. I mean, I think, as you know, surveillance for fungal infections, it's something that is not generally happening at the CDC. We have only actually now 2 reportable conditions. One is Coccidioidomycoses, and that's only reportable in 22 states. It's a nationally notifiable disease. So if a state chooses to report it, we will get that information at CDC. So that's one. And then the second one that we've made recently reportable is Candida auris. Again, it's state dependent. So for CDC to get information at the federal level, states have to make it reportable. So barring that, then we have to go and look for places to be able to find surveillance information. Probably the best way to do that is to establish our own surveillance system, which we've done for candidemia, as you know. So we have 10 sites that give us information on Candida in the US. This represents probably around 15% of the population. This is isolate-based surveillance. So the beauty of that is we get the isolates at CDC and we test them for susceptibility. We can do sequencing on them. We can verify their species, and we can track really well, at least a representative sample of what's going on. This is not real-time surveillance. This is after-time surveillance, but it gives us an idea, at least what's circulating in these 10 states or sites. They're not the entire state. And then finally, there's, administrative data that we can try to pull from. We all know the limitations of ICD-9, ICD-10 coding and what that means. And so we try to do that with some of these databases that are out there, but it's severely limited. So surveillance and improving surveillance and being able to get at data that is helpful and is more real time is one of our big goals here at CDC, certainly in the fungal disease arena. There are obviously other infectious diseases that have much better surveillance than us.
Okay, and another question before we get to our next speaker, Tom. How might you approach the real challenge of a very high burden of COVID in the community? Which, certainly if you live in a state like we do in Alabama, where probably 20% of the population has had natural COVID infection or more. So with that kind of background incidence of disease, how can you determine the relatedness of some of these fungal infections to the COVID? Now, for things like Aspergillus, where it's occurring right at the time or during a period of prolonged intubation or something, it's maybe a little bit easier. But how can you be more clear about the relatedness of COVID to the development of these infections?
Yeah, these are always challenging questions when you're dealing with somewhat rare disease and in a specific patient population where there are lots of other risks and lots of other things going on. But the basic way we do these sorts of studies is we try to find an appropriate control group, and so you have to have an appropriate control group to compare your new group of patients with this infection to a similar population of patients without or with the infection. And it could be at a different time period, a more historical control, but better would be during the exact same time period and collecting information on a control group with similar risks, and then trying to understand whether there's a higher risk of having that infection in these patients than versus the control group. Those are, as you know, hard sometimes to do, but but that's why when we try to collect case information, we also try to collect control information at the same time.
Okay. All right. Well, thank you, Tom. It's very helpful. It's a good start to our discussion. So our next speaker, if Tom Patterson is ready, we're a few minutes early, so I'm not going to complain about that. But most of you know Tom. Tom's a professor of medicine at the University of Texas at San Antonio Medical Center. He's professor of medicine, but also chief of the Division of Infectious Diseases, and he's also director of the San Antonio Center for Medical Mycology. Tom's had a special interest in molds, especially well, all fungi, but I think he perhaps is best known for his work in Aspergillus. And he, I think, is going to share with us some of his thoughts about COVID-19 and Aspergillosis, so-called Kappa-associated pulmonary aspergillosis in particular. Tom, thanks for agreeing to do this and look forward to your comments.
Oh, there we go. Thank you, Pete, and thanks to all of you for joining today. It is my privilege to be able to talk to you for a few minutes about COVID-19 associated pulmonary aspergillosis, Kappa, which we all have spent a lot more time talking about that than we ever thought we would, right? So hopefully these will be helpful comments for you. Hold on. There we go. Here are my disclosures shown on this slide. So here's a little outline of what I'm going to talk about today. Obviously, key questions are who's at risk, right? So not everybody with COVID gets Kappa. So we'd like to know who's at risk so we could focus our efforts. How do we make a diagnosis? That's really key. That's going to be important in making the diagnosis of a lot of these infections that you'll hear about today. What accounts for variability in detection? We've had a lot of variations reported across the spectrum in different regions of the world. And so I'll spend a few minutes on that. What strategies are useful in managing patients at risk for this disease who have it? And then I think hopefully it'll be helpful to look at some of our lessons learned from invasive pulmonary aspergillosis in the ICU generally without influenza or Kappa, and then influenza-associated pulmonary aspergillosis, because I think that helps set the stage for this problem. So I'll start with a case. One of the patients we had here in our hospital, June of 2020, which seems like, what, a decade ago, right? But a person who presented with increased shortness of breath, the medical history, you can imagine, morbid obesity, really large diabetes, hypertension, a week of symptoms, had tested positive for COVID at an urgent center, obviously did worse after that week period of time, which we see a lot, right? And then on the day of admission had progressive shortness of breath, called the EMS, O2 sats are shown there, placed on high flow in our emergency, admitted to the ICU, treated with the dexamethasone and remdesivir in a pretty standard fashion. You can see the chest radiograph there. Admitted to the ICU, then with diagnosis of acute respiratory failure. There's the CT, which obviously is something you guys have seen and girls have seen a lot of over this pandemic, right? Started on high flow, typically for us, bank ceftriaxone or zithro, pending NARES, PCR, et cetera, and a procal. Elevated D-dimer and was detected, so anticoagulation was done, and there you see the CTPE. The patient did require intubation, progressive respiratory failure, refractory despite antibiotics, and no improvement in the ventilator requirements. The tracheal aspirate was growing, Aspergillus fumigatus. So let's start with this a little summary of invasive pulmonary aspergillus in the ICU. Even if you just look at that diagnosis, even without influenza, other viral infections, or COVID, the incidence has varied a lot in different parts of the world and probably has a lot to do with definitions, but it also probably has a substantial amount due to how much we look for it. So obviously the issue of not having EORTC/MSG host factors has been a problem, right? So that's been something that has really made this a little trickier for us in that setting. Obviously, the varied sensitivity and specificities for various biomarkers and diagnostics in the ICU have been difficult, and biopsies are obviously not performed even in these intubated patients. These classical risk factors are not going to be present in most of them, and so it makes that diagnostic criteria difficult. The risk factors, newer risk factors for patients not being traditionally ORTC criteria, like COPD, liver failure, influenza, and others. So the question is, just for the invasive aspergillosis in the ICU, do the same issues impact Kappa and influenza-associated aspergillosis? Obviously, higher risk patients are going to be those with classic risk factors. In an immediate risk, things like steroids, COPD, lung transplant, et cetera, other immunosuppressive therapies. But certainly that's going to be Kappa now, right? A lot of those. And then lower risk would be those that are shown. So if you look at the use of EORTC, MSG criteria to diagnose influenza, IPA in the ICU, obviously it's a complicated scenario. A typical probable diagnosis would be those with host factors, the typical clinical features, which now have been updated. This is from a paper before that update by Blott and colleagues, looking at Aspergillus in the ICU, and then mycologic criteria. So it obviously was difficult to categorize these ICU patients with lack of traditional host factors. If you look at the criteria proposed in that manuscript by Blott, and then subsequently by Bassetti and colleagues, have done a really a great amount of work in this field. You can basically see probable EORTC criteria are those with the risk factors, but if you don't have the risk factors, that's more difficult. With probable disease, when you end up with Aspergillus, compatible syndrome, imaging, those sort of things with host factors, to end up with a putative diagnosis, right? And then if you meet more than one of those, when you don't have even one of those criteria, then you classify it as colonization. So with a host factor, you can end up with probable disease, but you end up with putative otherwise. But it seems to have held up pretty well to the scrutiny of Aspergillus in an ICU. So then it brings us to the question of invasive aspergillosis in patients admitted to ICU with severe influenza. And this work has been done a lot in Belgium, Netherlands, and Northern Europe, where they've really focused on looking at this in a really careful and extensive way. And it's because they really have made that diagnosis in a number of patients that then really seem to have impacted pretty strongly outcome in a negative way. So overall, in this series, published now a few years ago in Lancet Respiratory Medicine, the overall influenza, the overall Aspergillus diagnosis occurred in almost 20% of the patients with severe influenza, a median of 3 days after admission. So in immunocompromised patients, it was higher than in the non-immunocompromised, which you can see there at 32 and 14%. It also occurred, though, not only in influenza A, H1N1, but also influenza B. So resistant Aspergillus was also detected in about a quarter of those patients. But again, that's going to be reflected of their local regional epidemiology, where resistant Aspergillus is very common. It was also important to note that 90-day mortality was significantly higher in those with influenza, if they had Aspergillus or not. Obviously, influenza itself is a risk factor for mortality. That's what they're looking at. But sicker patients, the use of steroids was also very, very key. But they also point out not only did it occur, but you could have the potential for azole resistance as well. What about diagnosis in that setting? So again, this is patients with invasive aspergillosis admitted to ICU, and the importance of BAL and galactomannan testing in that setting. So again, in this study, that most of the patients with influenza-associated Aspergillus had BALs done. Again, we didn't have quite the concerns that we do with the COVID, right? So, although we maybe should, but the positive BAL cultures are shown there. Galactomannan with higher levels was present in most of those patients. And so that really was felt to be a useful tool. Serum galactomannan was tested in a little more than a third. 65% of them had levels that were 0.5. I thought kind of surprising at the time. You really wouldn't, I wouldn't have thought that. But I think we may see that with Kappa as well, which I'll get to. Obviously, it was associated with that higher GMs were associated with poor outcomes than those with lower GMs, suggesting more extensive disease, but the importance of pursuing BAL with cultures and GM testing. So that brings us to Kappa. So basically, early on, Ferric Fang and others who chronicled the sort of advances or issues in COVID early on, basically showed that, you know, bacterial and fungal superinfection seemed uncommon, but might be increased with longer ICU stays and immunosuppressive therapies, and also dealt with the secondary influenza issues. IPA in influenza and SARS was seen in some patients, not very many. They noted in the literature that the incidence of Kappa varied a lot from 7 to 35% and dealt with the issues I've just mentioned and talked about the importance of early treatment, but recognized significant gaps in knowledge, including diagnosis by non-bronchoscopic means, optimal treatment not known, and risk factors. GR and colleagues published in OFID about that same time issues about the postulated pathogenesis. Obviously, viral disruption was felt early on to be an important risk factor like influenza. Whether that is as true is hard to know completely. The impact of adjunctive therapies is, I think, almost certain. That is with corticosteroid use and immunosuppressive therapies like IL-6, JAK-STAT inhibitors, and others. This was one of the early reports, characteristics of patients with versus without Kappa. And you can see, obviously, small numbers. We've had a lot more cases now, but that many of those patients with Kappa didn't have typical host risk factors, right? That was an important distinction, I think, in early on. We recognized that. Certainly early, we didn't do many BALs, but mortality was recognized even with small numbers of patients to really be significant. These couple of studies I put together from Pratt's and White from Europe, including, but also in the US. This is from Lewis, is from the UK, but basically showed first with the ECMM study, but from Pratt's and Martin Hunagel, Oliver Corneli, and others, that basically showed a number of patients with Kappa. The median incidence was around 10%, but again, the range was big, 1.7 to 27%. Risk factors for Kappa probably also reflected local practices for treating Kappa in ICU at the time, but especially tocilizumab was an important risk factor. Obviously, everybody is likely receiving steroids by close to those times, so it's harder to sort out. Older age and invasive respiratory support is kind of a definition. In the UK, a countrywide study that that Lewis, White, and his colleagues conducted showed around 14% incidence. Mortality was around 38% versus 90. And so really high, I think, if you didn't get treatment, obviously you're not going to do well. So it really suggested that was important. They did find steroid use as an important risk factor as well as chronic respiratory diseases. You'll hear more about it later, but MSG 17 is a study that the MSGs embarked on at a number of sites in the US that's looking at describing the incidence in the US, and that study is ongoing, but we'll hopefully have data soon that lead to likely a prevalence of Kappa in the US ICUs, especially if a careful diagnostic look is being undertaken. The imaging findings are also important. Ground glass opacities, the crazy paving we obviously see in COVID. But later on, you may see, you can see a reverse halo even with Kappa. We think about that, the atoll sign being more for mucormycosis, but we certainly see it in Kappa as well. Later on, we see organizing pneumonia to more typical tree and bud with nodules, also an important feature that you might not see with just typical COVID pneumonia. But certainly, at least I think, and this article by approach from Kohler and Oliver Cornelli and a large collaborative group basically suggested multiple pulmonary nodules and cavitation should really prompt evaluation for Kappa and perhaps other opportunistic infections as well. If we look at the diagnostic methods for Kappa, they're shown here. Obviously, lung biopsy would be great. How many people with COVID early on got a lung biopsy? I would guess close to 0. I think now we're more comfortable with bronchoscopy. Obviously, people have better, more careful use of PPE. Obviously, people are also immunized, which is good, vaccinated, I should say, to keep that straight, with non-bronchoscopic lavage, an important feature as well. So what about tracheal aspirates? It's certainly easy to do, but you can certainly get colonization in that setting. I think what we would use a tracheal aspirate as a clue to attempt more invasive procedures like a non-bronchoscopic lavage or even bronchoscopy with a lavage in that setting. Sputum is going to be easy to obtain. Whether that's more representative than a tracheal aspirate is not known. And then serum testing is also, I think, useful. It's been positive more than I would have thought. Galactomannan is probably more useful, but certainly lateral flow assays have now been developed, which makes it easier to do in many settings that weren't probably typically done. And beta glucan, while it's not specific, so it's not part of our new definitions, can certainly give an important clue. There we go. So here's the proposed diagnostic criteria for Kappa as put forward in that Lancet ID article. Obviously in an ICU setting with ARDS, proven and probable, as you can imagine, higher serum concentrations are going to more likely be associated with disease. A BAL of 1 or more was suggested. In that GM of 1 or higher was suggested. Similarly, if you can imagine, probable diagnosis with lower BAL numbers if you have serum. PCR is not as well established in this setting, I don't think, but obviously if you end up with CT values that are lower, that's certainly going to be more suggestive of invasive diseases. We didn't suggest tracheal aspirates due to possible colonization, but again, I think you could use them as a clue for other tests. What about treatments? I think the important thing is to diagnose and to treat early. This little diagram suggested treatments not really being very different, with Vori or isavuconazole being sort of first-line therapy in that setting. It was really before the posaconazole paper was published, I guess, or before it was really very widely used. I guess it was published. But the liposomal therapy as an alternative, using serum for therapeutic drug monitoring, of course, and obviously the usual recommendations for monitoring. Azole resistance disease is also important, and there you may choose, if you have a high prevalence, liposomal therapy or combination of lipid azole and echinocandin. Drug interactions are important. Obviously with azoles, that's trickier, right? And especially in an ICU setting where we're getting a lot of cytochrome 3A4 interactions. That may be an advantage for isavuconazole, which is going to likely have fewer cytochrome 3A4 interactions, but obviously needs to be considered for all. This is the time you need to talk to your pharmacist, look up drug interaction software. What about prophylaxis? So just to close on the last few, this study, again, from Austria by Hotzel, also included Martin Hernagel, which basically shows in the patients who received posaconazole prophylaxis that you really didn't see a difference in mortality, although you do see a difference in the occurrence of Kappa. So I think the question is probably not really solved, and it may well be considered in those patients in settings where you have a high incidence of disease. So in the last couple of minutes for me, the MSG has worked to develop these care step pathways. Lisa Tushla is about to describe these in more detail for you. But I think they're really useful to try to outline a clinical approach for Kappa, and as you'll hear for other fungal infections as well. Obviously, screening for Kappa is important. It sort of gives you some clues on when to do it, like I've just described, whereas you may well use like colonizing isolates, like from the trach, as a clue for more invasive disease. The order of preference, as outlined in this care step, also talks about BAL or non-bronchoscopic lavage or other ET tube assessments of samples. Obviously, beta-glucan from serum can be important, and then GM either by EIA or lateral flow. And if you have availability of it, Aspergillus PCR as well. To evaluate for Kappa for treatment decision-making, obviously the diagnostic criteria are similar to that I've just described, but it really kind of outlines these here, where higher levels from GM from respiratory samples are going to be more associated with the likelihood of the diagnosis. And if you get a combination of even low levels of GM from respiratory samples, along with positive serum samples, that's really helpful in establishing a diagnosis. Treatment is outlined here. And again, our recommendations were for voriconazole, Lasavia, and Posa as a sort of first line with liposomal therapy, especially in areas of azole resistance, or if the diagnosis really isn't clear. You're going to hear more about mucor in a minute. If PK is going to also be important, it can be severely altered and in seriously ill COVID-19 patients. So that's again a time to work with your pharmacist. The QTC prolongation is also really key. And that also again may be a time where isavuconazole is useful. And we talked about drug-drug interactions. Go back to our patient, seen by ID, recommended to start Vori. Things did not go well. The serum collectome returned 1. A BAL was performed, which showed an index of GMI of 4.5 with extensive disease throughout the respiratory tree. And as you can imagine, that really didn't go well despite maximum support and really had changed to comfort care measures. So the take-home message is the importance of considering Kappa in ICU patients with ARDS. The diagnosis can be difficult. And even though the data is pretty limited, that early antifungal therapy may improve outcomes. We certainly hope it does. And with that, I'm going to stop and say, don't give up. We'll get through this. No te rindas. And thank one of our fellows, Sharon Angudi, for sharing this case in the slides. With that, I will stop.
Well, thank you, Tom. And there are a couple of questions in the chat, and I'd like to ask you to address a couple of things. I think it's clear that, the definitions are probably still in evolution. Or do you think that we've pretty much settled on some definitions that everybody can live with? Do you think they're going to continue to evolve? Given that most people don't do BALs on these patients, and in the European patients, at least, there seems to be a big emphasis on the BAL. How do you see these changing over time?
Yeah, so I think they may change a little bit as we learn more. I do think our pulmonary colleagues, our critical care colleagues, are more comfortable doing BALs than they were before people were vaccinated and before we knew about the COVID. But on the other hand, if you could avoid doing a BAL, I think you'd like to do it, right? So what I'm really hoping, even from our work with MSG 17, that we learn more about, like, especially the non-bronchoscopic lavage. That's kind of a term that's not, to my mind at least, always consistent in its definition, but it's more or less a blinded lavage, right? So you get a deep sample in a blinded catheter, so you're able to put it down and suck fluid back, right? So if those could be really standardized and used, that would really be helpful. And so that would be useful. I do think a tracheal aspirate is sometimes colonization for sure. We've certainly seen that ourselves here, but it can also lead, as I said, to more invasive tests that can be useful. So that's kind of my opinion anyways.
Okay. What do you think is going on differently between those who have this basically tracheal bronchitis, which is almost a necrotizing process, and those that have quote unquote parenchymal disease? you have any thoughts about that?
Yeah, that's also a pretty tough question because, you know, it kind of like we see with invasive, that is what you see with influenza associated Aspergillus. You know, so some patients will end up with bronchial disease, whereas others are going to have a tracheal, more like a tracheitis or tracheal bronchitis. And so I think that's something we'll also, that more data would really be useful. And I wonder if that some of the patients in essence get disease because they have COVID and others get it because they have the COVID treatments. So I'm seeing somebody said, what about, you know, we know steroids, we think we know steroids really help in COVID, especially in intubated patients, right? We don't have that many other options. How do we manage that if we think this is associated with Kappa? I think we know a couple of things. One is we don't give higher doses than of steroids than we need to. And I think just this last week, there were studies that looked at the 12 versus 6 dose and didn't show a difference to the preprints that outcome anyways.
Someone in the chat has asked what you think about different species. Is it common to have 2 organisms, 2 different Aspergillus species? I mean, the dominant organism seems to be Fumigatus, but in some sites, other organisms are showing up. Flavus, Niger. Any comments on that?
Yeah, that's a good observation. I think we've definitely seen the same thing. So my opinion about that, what that would be, you know, especially like Niger doesn't cause that much invasive disease. So it makes me wonder if patients don't get colonized and then they end up becoming infected with Fumigatus, right? So that's what I'm wondering if this happens in that setting. So that's why I'm going to use those tracheal aspirate isolates and to do a lot of them, so you can use it as a clue. So if you have Aspergillus there, then you're going to be much more keen to make a diagnosis of, or look for the diagnosis of lower respiratory tract infection.
Another question from the chat, which I think is probably the $64,000 question, and that is, how do you explain the difference in the clinical diagnosis, the observed diagnosis of Kappa in living patients compared to those who are autopsy patients?
Yeah, so
because there does appear to be a big difference, and sadly, not a lot of autopsies are done. But anyway, what are your thoughts about that?
yeah, so I'm agree with Lewis. So that question was from Marcio Nucci, who always is a very careful thinker in these areas. So it's definitely a difference and important to sort out. I do think, like Lewis answered, that autopsy is obviously highly specific, but not necessarily very sensitive. So I think it's hard to know. I think you see those curves that I showed of the prophylaxis where mortality was the same, but you see really pretty strong evidence of infection in those patients in the study that looked, the Austrian study that looked at prophylaxis. It says to me, I'd really want to do it, even though it's hard to, you know, maybe you're over treating some that are really just colonized, but it really make me want to consider that in high risk settings. And the same way for preemptive therapy. I think, as Cecilia says, you know, you think about preemptive therapy in folks that aren't getting better, especially if your CT is suggestive or if you can't get a CT, right? So I think that's something really to consider. That's one of the real points of this MSG 17 is to say, by looking at the diagnosis carefully, does that really help define it better? And I think it will. So to give a couple more words about that, I forgot to add a slide in, I apologize. But you know, this study looks at, so the study is literally taking respiratory samples that are in the lab that were done clinically, but it's basically sending them to a reference lab at UAB to do a whole battery of tests on, right, including PCR. So if you really, I think it's going to help answer a lot of our questions on how often should we do these tests? Does it really help? You know, do these other adjunctive measures for diagnosis really help improve that? Okay, so Luis is on to what about Kappa being infection control? I don't think it's infection control, but I'll tell you, we have had 2 pairs of patients that were right beside each other at the same time that made me wonder about that. And so I think it's important, you know. I think a lot of infection control things in COVID, when things are really bad, don't go that well, right? So we've had HAIs that have exploded, right? You know that too well, Luis. Maybe not at your place, but I've heard it's happened in other places, right? You know, that's important. So if you could easily imagine really super busy people could make an infection control issue, right? Just like hand carriage of Prophylaxis or Auris or whatever, right?
Tom, thank you so much. This is just a really insightful presentation. Great questions. I think we got to most of them, but we'll talk later. Okay.
Thanks.
Our next speaker is Lisa Tushla, who's President, CEO of Terra Nova Medica. Terra Nova Medica is a strong CME partner with the MSG ERC. We've worked with Lisa for really a couple of decades through a number of different activities. And Lisa is going to describe the Fungus Education Initiative that is being sponsored by CDC Cooperative Agreement. So Lisa, with that, I'll let you take it.
Okay, sorry for the delay. Can everyone see the slide?
Yep, looks good.
Okay, great. We're really pleased to be here to share something not so clinical, but a little more educational with the group. And we're very pleased to have been invited here. We've enjoyed a longstanding collaboration with the MSG and now are really enjoying working with the CDC on this initiative as well. So this project, this was a cooperative group agreement as part of the COVID outreach from the CDC. The educational grant was actually to University of Alabama, and then the University of Alabama worked with the MSG and our team to develop educational materials. Some of these are CME and others are what we'll call non-branded education. And so you're more than welcome to look at the MSG ERC site as well as the flagship site for this initiative, which is covidandfungus.org. We also have some of the continuing education activities. We've got one live on Fungus CME now, but there will be a second one launching shortly. So the challenge that we were up against, and I think this has been iterated in some of the earlier presentations, are some knowledge gaps regarding the awareness of the potential for IFIs in the severe COVID population. So as you know, there's a low level of awareness and the need to teach people to think fungus in general. But you know, you've got busy practitioners with a pandemic, and so to get them to think about fungus was very important. There was also a lot of confusion over the nature of some of these CAIFIs, particularly in mucormycosis in India. So we're going to go over some work that Alon did to help us address that issue very quickly when that issue came to forefront. The other question and issue you have is who is our target audience? As we know, it's not just ID physicians, but it's intensivists as well as intensive care pharmacists and nurses that need this education. And many of these are not experts in mycology. The other point that came to fruition very early in our discussions that there's varied resources in terms of diagnostics as well as access to therapeutics, particularly when the mucormycosis issue hit India. So it's important that whatever we developed had a community focus, particularly for those resource limited settings, which I'm sure Luis can tell you about some of the Latin American outreach. As you know, we have moving data. As the pandemic evolved, our infections of concern shifted. We had risk factors shifting as we started to get vaccinated individuals. But we, you know, it's nice that this agenda will cover some of those rarer infections or infections that are emerging beyond Kappa. We needed to be flexible in the way we were working with. We had a one-year grant to do this and to get some guidance out, but also to be able to pivot when emerging threats happened. The other issue that's interesting is there's, as many of you know, underserved populations are more likely to experience severe COVID and IFIs, but what is that driver and what are the best strategies to address that? So we've got some work that's going on in terms of looking at the research, but also addressing some of the need to get people vaccinated in these underserved populations. So the solution was really to create the COVID and Fungus Initiative, which was to raise awareness of the busy professionals to think fungus and get them the tools they needed to both diagnose and manage CAIFIs. And in targeting this population, we realized this is a large group of people with varied interests, so we used listservs, but we also used a Google AdWord campaign that allowed us to get education not only to healthcare providers, to those patients that might be looking up black fungus and some of those color coding documents that seem to be a little confusing. We also use social media and continued education promotion, and we've been working with the CDC directly on some of their social media campaigns and included a program with the Fungal Disease Awareness Week. And Alon Schwartz has been really helpful, and as well as Luis and Andre, to help us get some materials out via Twitter. As I mentioned, it was important to be responsive and to be able to move quickly with new findings. And we wanted to use convenient formats. So we used something called a care step pathway model, which we've used in oncology for secondary infections and other side effects, as well as infographics, as well as traditional live virtual events, videos, journal publications, and podcasts. So I'm not going to spend too much time on the initiative goals, as it would make sense that we really want to help people think fungus in these patients, but also recognize the signs and symptoms and perform appropriate diagnostic tests. Timing and appropriate selection of antifungal therapy, you know, this is we don't really know yet where prophylaxis and empiric therapy are going to fall. We leaned on the side of helping people recognize patients at risk and actually screening those patients and coming to a firm diagnosis. But as you'll see from some of our materials, it's really a question for people. Optimizing pharmacology of therapy, you know, we've worked with Dr. Johnson about this, and it's really important to recognize the baseline immunocompromised state and how that affects drugs delivery, as well as drug-drug interactions in these populations. As we know from Dr. Ostrowski-Zeichner, there's really some important infection control and prevention procedures that need to at least be considered, and this came through very loud and clear in the Latin American outreach that we did. The healthcare disparities, we're trying to delve into that with some research using databases with Dr. Badley. And we want to educate patients and caregivers at CAPA and CIFIs. We were very fortunate to have some really fantastic patient videos, including a caregiver. Miss Angela Stroman helped us with that in terms of what is the perspective of the caregiver when you've got a sick relative in the ICU with a potential fungal infection. Okay, so I think you know many of these people. Dr. Pappas was the chair of this initiative, but Dr. Thompson and Bradley were very, very instrumental, and Dr. Jones was particularly helpful in bringing in a lot of resources and keeping this thing moving. In terms of our staff, it's myself and Tom Davis are the main people at Terra Nova, but Dr. Lyman, who's going to be speaking later, has been a wonderful partner to us as we worked through this program. Our content development team is a wide range of experts in infectious disease, intensive care medicine, pulmonology, disparities research, and medical microbiology from the US as well as throughout the globe. So we're very pleased to report that our website for the COVID and Fungus Initiative launched in March of 2021, and to date we've had almost 22,000 visitors. The initiative has been accessed from about 151 countries and translated by browser into 187 languages and dialects. One of the values of our our Google Ad brand is that we can target different regions of the world as the pandemic changed. So that was really good for us because, as you'll see, the mucormycosis outbreak in India required a lot of geo-targeting. The content's been viewed evenly on mobile and desktop devices, and we think that's important to reach some of the underserved populations, whereas, you know, maybe people have access to a cell phone, but not necessarily a desktop computer. We've done a range of tactics. I'm not going to go into detail. You're more than welcome to go to COVID and Fungus, but as you can see, it's a lot of resources, it's live events, it's 2 Twitter open mics and an infographic on mucormycosis. So we've really developed a lot of things in particularly a podcast in conjunction with the IDSA. So we've tried a bunch of different tactics and we've been monitoring how these perform with different audiences. If we kind of look at our tactics in different kind of categories, we've done guidance and research. So the Kappa CSPs that Dr. Patterson described is one of the main parts of this, but we did create a mucormycosis infographic working with Dr. Schwartz as well as some of his colleagues in India. This whole idea of the color miscoding was really brought to the forefront by Dr. Perfect and looking at the black fungus, and then it turned into white, yellow, and green. And so we actually created a document that provided some guidance on that. That's been one of our most successful initiatives that we think is being reached by both HCPs and patients. The OFID journal article is actually in press now, and so Dr. Badley led that. He's also leading some database research, and as Dr. Kappas mentioned, there's also a crypto registry. In terms of building the community, we've had 2 open mic Twitter events. The first was on mucormycosis. The second was actually in conjunction with Fungal Disease Awareness Week. That's been widely successful. The Latin American webinar that Dr. Ostrowski-Zeichner led was also very well attended and had a lot of interaction, and we're looking forward to learning more about the needs there. And then we did a number of case discussions on the care step pathways and the other materials. And so there was a call for cases where people from the community sent in cases and the challenges that they had recognized. And we workshopped those on a CE on expert guidance and a second continuing education on multidisciplinary care that's coming out soon. We also took one of the cases and worked through it in a critical care nursing journal publication with Dr. Jones. And that's been a really nice opportunity because the nurse who was the daughter of the patient actually came through and was able to provide some commentary, expert commentary about the perspective of the caregiver. In terms of those patient caregiver resources, we've got 2 videos from patients that had survived these CAFIs, as well as disparity resources, as well as COVID-19 resources in general. If we want to drill quickly down on 2 tactics, we did have to address the mucormycosis in India issue. And as you know, that was not something that was on our radar at the end of 2020. But in dealing with that, it seemed unexpected, but then we started to dive into the fact that there were high levels of mucor in India in general, as well as a problem with uncontrolled diabetes in India. And so the experts helped us kind of tease some of that out. However, there was a lot of confusion caused partially by the Indian lay press with this idea of the black fungus, which was more to do with the skin color than obviously the fungus. And there was also confusion over the role of durable medical equipment as a source. So there was really a need to educate quickly and help not only the healthcare providers, but the patients in that area. And as you know, India has some resource limitations regarding testing, access to surgery and treatments. To address this issue, we worked with Dr. Schwartz on a mucormycosis infographic that we developed with him and were able to get out within a week and a half in working with his Indian colleagues. And we hope to learn more about where we are in the state of mucormycosis in India. That has had 276 page views and 2.5 minutes average time on page. So that's been really successful. The Twitter open mic that Dr. Schwartz did with his colleagues in India drew 100+ participants. We set this up and he ran it within a week. And so many of the experts from India were able to get together with their colleagues and learn from the MSG and the CDC very early in the process. So that was great. We did a podcast with the IDSA that was a quick hitting podcast with Dr. Schwartz and Speck. And that collaboration and co-marketing really allowed us to extend the message. As I mentioned, we developed a kind of a color coding miscode, let's clarify this miscoding content. And we worked with Dr. Revankar on this, who's an expert in molds and different types of fungal elements and their colors. And we were able to get this out and has had 1,186 page views to date with 2.46 minutes on site. So I don't know if any of you do web marketing, but that's a really long time for people to be perusing content. The mucormycosis issue was also addressed in our first CE activity with Dr. Contianis talking with his colleagues about that as well. So that was great. In terms of the CAPA guidance, I think Dr. Patterson has done a really good job explaining this. One of our challenges that the guidance for CAPA did not necessarily include a wide range of screening options that would reflect what's available in the community. So we wanted to really help people understand what diagnostic signal they might see from the microbiology and a flexible, easy to use format. So this care step pathway was actually initiated and worked through in the oncology space allows you for assessment, kind of grading criteria, and then quick hitting information for diagnostics as well as treatment. And so this was launched in 2021 on the website, but we've also done some hard copy distribution to UAB as well as to the community hospitals around Duke Medical Center. And that was at the initiation of Dr. Melissa Johnson. And to date, we've had 1,000 one-page views on the website and 2.41 minutes on the page. We also created a comprehensive reference companion guide that addressed antifungal stewardship and infection control issues with Dr. Ostrowski-Zeitner. I'm not going to spend a lot of time on the details of the CSP because Dr. Patterson did a really good job on that. But I do want to mention that we did illustrate the use of the CSP through 2 CME activities as well as the Critical Care Nursing Journal. And so those CMEs will, that are going to be promoted more extensively in the next weeks will really drive a lot of people to the care step pathway. Just real quickly to end up, we did an initial feedback on the CSP, and what's very interesting to us is that it is getting widespread use among intensivists, critical care pharmacists, advanced practice providers. We're in the very early stages of this survey, but we're looking forward to collecting more information and seeing how it's being used. What's really interesting to us is that 43% of the respondents said they are screening for Kappa, but some are treating empirically. Others are screening since they started looking at the CSP, so this is kind of a new idea for them. And some are not screening for Kappa because they don't think that there's enough of it. And then some are testing only in the presence of unexplained clinical deterioration. This was really interesting to us, again, with small numbers, but we asked people, what's your estimate of the prevalence at your institution? And a lot think that they're seeing about 1 to 2% of their patient population with Kappa. And then there's a little blip of people that think that it's greater than 10%. So I think it's really important that the MSG research and other groups get out there and help us to get a good handle on this prevalence. Most are actually found that the most helpful aspect of the CSP was screening, but the definitions of Kappa, which were made to be pretty inclusive without a possible category, I think were very helpful, but they also, wanted the clinical criteria and the guidelines for other IFIs. We don't know what impact it has made yet. Obviously, it's very early in the game, but at least a quarter thought it was decreasing mortality in terms of being able to recognize this. And then really people want to see more case reports on using the CSP, as well as getting to the bottom of this prophylaxis versus empiric versus directed therapy question. A lot of interest in mucormycosis, candidemia, and diagnostics in general. So I think the MSG is on the right track with some of the content that it's looking to do. So we're just really pleased that our activity has reached a large, diverse audience. There's still a large unmet need for education about the range of IFIs that can affect these patients. And we look forward to expanding the educational offerings with CA IFIs as well as more general fungal topics in the next 12 months. Just want to say thank you and really appreciate the opportunity to talk with you.
Well, thank you, Lisa. And we have a couple of minutes. Questions. I was looking. I don't have anything in the chat. No, we don't have anything in the chat at this point. Lisa, let me just ask you an open-ended question, and that is specifically, what do you see as what are the biggest challenges to reaching a larger appropriate audience, a target? What are the biggest challenges to reaching an audience that you really want to get to? What do you see those, and how can we address those and try and fix them?
Yeah, so I think one of the things we learned is that the intensivist audience really needs this education, as well as some of the ancillary members like the pharmacy, pulmonology groups. And so we have the ability to do some of that through our Google Ad Grant campaign, But also, I think some of it has to do with having the faculty in place that represent their discipline, and so that they're hearing from their group kind of held up within that multidisciplinary framework. And so between the CME activities, which give us the opportunity to go to specific targeted groups, it's really bringing that, and I think the MSG's done a great job of bringing those specialists into the fold. I think Chadi was here, and we've worked with Melissa Johnson, and now we're starting to bring some advanced practice providers in as well. So I think representation within activities that show the multidisciplinary care team are important, but also that ability to target through the continuing education activities, social media, those programs as well, and inviting those people to participate as well in the Twitter sections, because one of the things we learned is that's where a lot of the discussions tend to happen as well. So I think we've been moving in that direction with a lot of the MSG education recently, but I think it needs to continue, particularly during the pandemic. And I think having short materials that people can access quickly, because everybody is so busy. We saw people kind of get a little reprieve from COVID, and then, with Delta, they got busy again. So I think having quick hitting education makes a difference as well.
Okay. Thank you, Lisa. And kudos to those who've really chipped in. They're too numerous to mention at this point, but I know you mentioned Milan, but all those on this advisory group have been, I think, very helpful. Okay, we'll move on to our next speaker. Dr. Arunalo Chakrabarti is a physician in India, and he is a professor of medicine in the Postgraduate Institute of Medical Education and Research in Chandigarh, India. His topic today is COVID-19 and mucormycosis, and there's probably no one in the world who knows more about this, particularly in the midst of many thousands of cases. And so, Arunalo, thank you so much for joining us. This is a pre-recorded talk because of the time difference.
Thank you from Mycosis Study Group who has invited me to deliver a very important lecture on COVID-19 associated mucormycosis. During this outbreak, media has reported black fungus, white fungus, yellow fungus, and I would say that these names created more confusion, so rather we should avoid it. Now come to the mucormycosis issue of the topic. I would say that in India, mucormycosis is nothing new because we see very high incidence, nearly 70 times to the world. But COVID-19 associated mucormycosis is unprecedented. It's a storm, or it can be said of as a tsunami. And first time, mucormycosis is declared as the notifiable disease in India. And by the August 3rd, when the government portal completed this particular reporting of COVID-associated mucormycosis, there is already nearly 50,000 cases reported. And the same portal mentioning it is very likely that actual figures are considerably higher than this. Now come to the story since 2020 at the beginning. This was the first case which we had come across when we found in a COVID patient, uncontrolled diabetic. Then the patient had cough expectation. Patient was negative for galactomannan and beta-glucan, but sputum was positive for Rhizopus microsporus. So we diagnosed or thought to be as a probable case of mucormycosis. The patient was treated with liposomal amphotericin B, then posaconazole, and that time we found there are 5 cases of pulmonary COVID-associated mucormycosis reported. Of these, the 2 were diagnosed post-mortem, 1 who had both rhinocerebral and pulmonary mucormycosis. So what we found is that diabetes, ARDS, renal compromise, curdling diagnosis and surgery, making this scenario quite complicated. By the time we started seeing occasional cases of rhinocerebral mucormycosis, suddenly there was a report of 18 cases from one city, Bengaluru, which is in the southern part of India. From 3 centers, eye centers, they reported 18 cases. That raised the antenna of all of us. So I contacted the European Confederation of Medical Mycology as well as our International Society for Human and animal mycology, we tried to compile all cases which is COVID associated. We found majority of these cases are from India. And if you see in India, the cases were mainly rhino-orbital, not the pulmonary variety, the others were getting pulmonary. And what we have seen amongst these cases, the mortality is much higher in case of pulmonary group than the patients with rhino-orbital group where CNS involvement and when there is no CNS involvement. So we planned this study in the end part of last year, that is from September to December 2020, 16-center study which we have started. We found that this COVID-associated mucormycosis has increased the mucormycosis rate so much compared to 2019, and the same centers, there is more than twofold rise is already been there. Second important fact what we found is that this is the older male patient who suffered. And if you look into the prevalence-wise, it was 0.27% of the patients who are treated with COVID in the hospital and 1.6% in the patients who are treated in ICU. What we found is that majority of the cases were nasoorbital mucormycosis, but the patients were already coming late to the hospital because 1/4 of the patient, they have already the brain involvement which is there. Diabetes and steroid were found to be very significantly associated, but 1/3 of the patient, there is no diabetes, only COVID. But they also received the steroid, that was the major important factor. Next important thing, what we found is that these patients acquired this mucormycosis or were diagnosed of mucormycosis after median 18 days of COVID diagnosis. That means by the time they are discharged from the hospital, they are coming back to the hospital with this mucormycosis. That was a very important finding, and that helped in case of future control. And by multivariate analysis, what we found is that hypoxia and inappropriate steroid was very important risk factor. Then another study which came in the early part of this year, January to March 2021, it is in at three centers, but the report was almost similar. They have got in patients in ICU around 1.8%, we have got 1.6%, and similarly, a later part of the COVID diagnosis, they acquired the infection. But what they also found that the mean ferritin level was very high in this group of patients. But friends, everything went up. There was an unprecedented surge which we have found in April and May. Compared to our December, this data showed there is a tremendous rise which is being there. So this was the first paper which had come from the ophthalmology group. And this particular group, nearly 3,000 patients which they have looked into, data-wise they have shown this similar picture. But what they have shown is that they have shown mortality 14%. But this was very, very early report. They have not looked into 6 weeks or 12 weeks mortality, which was very important in case of mucormycosis. But what you can see is that this is very important, that most of the cases of mucormycosis were in the western part of India. Then it is in the northern and southern part, very few cases in the eastern part of India. So during this time, there are myriad hypotheses. Many people said it is the mucorales, spores around the garbage, construction activities, because of the makeshift COVID-19 facility, contamination of the oxygen supply, respiratory equipment, humidifier, water, reused face masks, zinc supplement. So many things came in the paper and people started claiming this would be responsible. So we went on studying one after another. First thing we look into whether zinc supplementation is important or not. At least in vitro, we found that the 50% of the isolates has significant growth in presence of zinc enriched media. But what we found in the patients and control, there is no rise in zinc concentration. There is nothing which we could say that zinc is playing important role or contributing in case of pathogenesis of mucormycosis. Then we looked into the iron issue. We found that the medium serum iron and total iron binding capacity, both are significantly low in case of COVID-associated mucormycosis. This paper is just Yesterday had been accepted in Mycosis journal, and you can see that serum iron in case of the cases and total iron binding capacity significantly low compared to the control. Then this is the very important study. It is just we have submitted for publication. This particular study is the environmental study at 11 centers. And we try to first choose this center depending upon the prevalence of these cases which have been shown. There were centers from the western part, there is centers from the northern part, southern part, and also eastern part. This study had shown very important findings. First, in case of oxygen pores, we have sampled nearly 137, but none showed mucorales. Oxygen cylinder, especially people claim that industrial oxygen is very important factor. None had mucorales. Humidifier water, there is nothing which we could find. But what we found is that in case of the 172 mask, that is the cloth mask, which was repeatedly used in the patient, only in 3, that means around 1.7%, there is mucorales being present. But what importantly we found is that air conditioning vents, where the presence of mucorales are there, and if you see in the room air, whether it is air conditioned or even non-HEPA filtered room and outdoor air, the spore count of mucorales is very high. Next, very interestingly, we observed that in case of outdoor air, there is rather in North India, the mucorale spore counts is higher compared to the South India, though as I've shown already, the case numbers are much more in case of western part of India. And what we found that in all samples, yes, Aspergillus is the commonest one, then is the mucorales, and amongst the mucorales, it is the Rhizopus aereus is the commonest one we found. So our study, the conclusion of this particular environmental study is that neither oxygen port, oxygen cylinder, or humidifier water had mucorales contamination. 11.1% AC vents had mucorales, and it requires regular cleaning. That is very important because of this, air has been got more mucorales in the hospital. Only 1.7% of the used cloth mask contain mucorales fungi. So mask cannot be the major source of the outbreak. However, if you see isolation of these fungi from oxygen source, humidifier, water, respiratory equipment, mask is a matter of concern. So overall in India, we need to improve the housekeeping activities of the hospital. High mucorale spores in both indoor and outdoor vicinity of the hospital is a serious issue. What interestingly, we found that overall spore count in the year positively correlated with the number of COVID-associated mucormycosis patients treated at the respective hospital. But I would say that there is a caveat. Some of the patients, they had come from home environment. So what it happens is that generally the patient when discharged, even in the home environment, there is high mucorale spore count. So they need to use universal clean mask, especially in the patients having diabetes, going even into the home environment, they should keep at least for a month. When they have immune dysregulation, they should minimize the exposure of mucorales. Friends, this story of mucorales in the ear is not very recent story. Even earlier, we have shown that at different season in hospital and outdoor, in India, there is high mucorale spore count. And the common species is always the Rhizopus aereus. So what we have learned from these CAMP cases is that there are 3 contributors. One is that uncontrolled diabetes factor, indiscriminate steroid use factor. Now high environmental mucorale spore in the air is another factor. Now the question is, why is such a high surge rate? Friends, if I have to narrate this story in this way, during this period, there were so many cases of mucormycosis, not mucormycosis, first I would say COVID. During this period, that doctors were seeing the patients not only in the wards, they are seeing in the corridor, they are seeing the patient in the pavement even. And they had no time, that time, to control their blood sugar, to check their blood sugar. Rather, they were trying to save the patient. So what had happened by this time also, there is oxygen crisis. So they went on increasing the steroid dose to compensate the oxygen which is not available. So what had happened that instead of 6 milligram dexa, some of the patients where they have given 30, even 40 milligram dexa, and that is increased the blood sugar. You know, have you heard that blood sugar of 700, 800? These were seen in this type of patients. So I would say that steroid, diabetes, and environment, all these factors played together. Of course, COVID also possibly played an important role. This recent publication has indirectly proven this theory. This is one of the hospitals in Mumbai, which is in the western part, where there are plenty of cases of COVID-associated mucormycosis were there. In this hospital, in ICU, they have treated more than 1,000 patients. And if you look into this ICU patient, 915 received steroid, 1,417 had diabetes as comorbidity. And they had seen the patients during even April and May 2021 when their COVID-associated mucormycosis outbreak was going on. But what they have done, at least as a protocol strictly in their hospital, they have maintained a steroid protocol. They have not allowed prednisolone to be given more than 40 or 30 milligram, and never allowed this steroid to be given more than 6 days. And a nurse-driven strict glycemic control regimen was also being practiced. So what they have reported, there's no case of mucormycosis reported during their stay in the hospital and during immediate outpatient department follow-up. So this indirectly shows that the inappropriate steroid use as well as diabetes is an important risk factor in developing mucormycosis. Friends, we have started doing that study of this second wave where we are trying for a case control. This very preliminary data, just for the sake of discussion, I have brought this data. We are still collecting the data. Possibly will go nearly 2,000 or more than 2,000 CAM cases and nearly 4,000 controls. This is the 17 centers data of 736 CAM cases, and controls are the COVID positive, but not having COVID-associated mucormycosis. What we found is that this population, especially the cases, they are from the rural origin. Diabetes is a very important factor. Hyperglycemia is also an important factor. Decay, though numbers are less, but still it is significant. But earlier we reported hypoxemia. Possibly hypoxemia is not an important risk factor in case of this mucormycosis. Steroid use without hypoxemia is an important risk factor. Zinc supplementation has now been found to be important. And if you look into the leukocyte count, there is no lymphopenia, which should have been discussed. This is 12% lymphopenia to disturb this aspect. So when we had done the logistic regression analysis of these cases, we found the same thing: diabetes, hyperglycemia during admission, and the patients where glucocorticosteroid had been given without or in absence of hypoxemia is very important factor, and mechanical ventilation is also. Site involvement, when we compare the COVID-19 associated mucormycosis with the non-COVID mucormycosis, we found that here rhinoorbital group is much higher compared to this non-COVID associated mucormycosis. This particular study would take another month for giving you really a good data on this aspect. So friends, what is happening in case of this COVID, diabetes, and mucor? See, in case of the this COVID patient, in relation to the diabetes, I would say 4 factors causing the hyperglycemia. If the patient is already having diabetes, and by this time we come to know, or we have known that COVID-19 virus also damages the pancreatic beta cell and elicits the beta cell impairment. Steroid also raises the blood sugar. And finally, what we have come to know is that there's stress-related hormone because of COVID stress causing. So these 4 factors, diabetes, COVID, steroid, and stress, that causing the hyperglycemia. When these patients is hyperglycemia, they have got an inflammatory state. And then there is an alteration in iron metabolism. Hyperferritinemic syndrome, this is causing excess intracellular iron, and this excess intracellular iron causing reactive oxygen radicals to be released, causing damage, and so free irons come in the circulation, which is a good food for mucus. Besides this, we also have seen there is endotheliitis. This endotheliitis has been shown in case of autopsy data. And this endotheliitis has got very importance because you see there is this endothelial receptor glucose regulated protein or GRP78 is upregulated, which help the cortex to be attached. So with this cartoon, we tried to explain this, the high glucose, free iron, siderophores. First, there is endoplasmic reticulum stress. So GRP70 is upregulated, where cortex is adding here, it causing cellular damage in the cells and ultimately penetrating and entering in the blood vessel and finally causing ischemia and hypoxemia. So we have spore high count in the year, but generally healthy people are not having this infection because of their innate immunity. But here COVID-19, steroid and diabetes are playing important role. But we are not very clear how COVID-19 exactly causing damage other than pancreatic beta cell, other than endotheliitis, whether they are also damaging the especially innate immunity or not, that we are at present studying. So what are the unexplored areas till now? First, in case of the COVID-19, I just mentioned that we are looking into whether it is disturbing the mucospecific immunity. That is very important. Second important thing, role of fungus. Is there any genetic susceptibility of Indian population? Though common isolate is Rhizopus aereus, we are looking into whether it has acquired some virulence or not. We are also looking into, though we have already shown that industrial oxygen humidifier masks are not important, but whether there is any other environmental factor. Now coming into the diagnosis, rhino-cerebral mucormycosis, there is not much problem because if you just collect the sample by ENT specialist, easily by calcofluor you can diagnose. And even in culture within 2 to 3 days, you can see the growth, but only thing is that you should not homogenize the sample. But the problem, and here another thing happened. You know that during this time, we have seen not only mucor, in some of the patients, initially it was 5%, but possibly now it had gone up to 10%, that both Aspergillus and mucor are present in the same patient. So that's a dual infection which is there, and that is also creating problem in case of pulmonary mucormycosis. Now, in pulmonary mucormycosis, it is not such straightforward diagnosis as in case of rhino-cerebral. Here, the symptoms and radiological signs are non-specific, overlap with COVID-19 as well as COVID-associated pulmonary aspergillosis. So we encourage now in our centers that go for bronchoscopy, collect the BL sample, try to look into transbronchial biopsy, and if there is possible, do a CT-guided lung biopsy. And at the same time, if there is an imaging reverse halo sign, thick wall cavity, bird nest sign, or mycotic aneurysm, though it can also be in Kappa, but it is more commonly in case of CAM. And on the top of that, if there is repeated negative galactomannan, beta-glucan, or Aspergillus-specific PCR, it suggests the COVID-associated pulmonary mucormycosis. Besides the pulmonary mucormycosis, we have also started looking for cases of gastrointestinal invasive mucormycosis, but these have been all diagnosed accidentally. Earlier also, when we tried to review in case of the gastrointestinal mucormycosis, we found that the mortality is very high in this group, and these are diagnosed accidentally during surgery and autopsy. But what we can do in this group of patients is that, there is the triad of shock, which have been seen significantly in this group, especially in pediatric group. Children also with a broad spectrum of antibiotics has got more chance having it. Adults, when there is abdominal distension, there is chance of having these cases with fever with GI bleed. Now, here very importantly, we try to train all the clinicians as well as the patients because the patients are discharged from the hospital, then they are coming back. They should not delay for their attention to the clinician. They have been advised with these initial symptoms, what can be seen. Generally, we know nasal blockage, congestion, nasal discharge, facial pain. These are the early symptoms in nasoorbital area. But interestingly, we found this time, good number of cases, there is jaw involvement and there is loosening of the maxillary teeth. There is, of course, in the later part, blurred vision and all those in the orbital involvement when it is there. Pulmonary mucormycosis is a big problem. Here, as I've said, the symptoms and signs are not very non-specific to say. Only thing is that it should have increased awareness and the antenna should be high for diagnosing these cases. While this outbreak was going on, another important challenge we faced, that there is no amphotericin B or liposomal amphotericin B. So there was a crisis in that scenario. So again, in our ECMM, along with the ISHAM, we tried to look into this issue together. And we have recommended this issue saying that if you don't get liposomal amphotericin B, start giving the amphotericin B deoxycholate and or itraconazole, or isavuconazole or posaconazole. When nothing is available, then we have suggested for going for itraconazole. Now, in orbital mucormycosis, some of the doctors in India, they tried with some of the local installation of this amphotericin B. They have said that the medial orbital resection with orbital decompression and retrovalvular amphotericin B injection, which they have tried. Initially, they have shown encouraging results. But I would say this approach is difficult decision, require multidisciplinary expertise and close monitoring. And orbital extension is warranted when extensive initial orbital involvement and with worsening of the disease that is being there. Friends, when this outbreak was going on, several misinformation and misleading facts were there. One is that black fungus, mucormycosis said to be contiguous, which is not. We have to train them. It is not spread by through oxygen, humidifier, water, or mask. No antifungal prophylaxis is recommended, but a lot of people started giving prophylaxis, which is not correct. Many people have been treated when this liposomal amphotericin B is not available with voriconazole and fluconazole, which we had to really struggle to stop in this aspect. And sometimes when drugs are not available, they are going for combination of antifungal therapy. That is not recommended, and there is little evidence in support of combination therapy. Even when this onion is having this black color, they have started calling whether it has mucor, or in your refrigerator, if there is this black fungus, is it mucor or not? So we have to show how this mucorales, especially the Rhizopus aereus, they look like. That's the real struggle we have to do with this patient. Now the question is how to prevent this COVID-associated mucormycosis. That really we did, and that would help by delivering lectures after lectures. We did this good glycemic control now. We had rationalized the steroid use. That is very important. Third important thing, we have started advising this patient with universal masking at least for a month or two. During discharge of the patient were advised what are the early symptoms and signs. So friends, summarizing what I tried to tell you is that this is a very important outbreak happened where we learned a lot of things. During this, major issue was steroid and the glycemia control, which was poor. This is the major issue factor which has been there. We have suggested how to suspect the disease early and advise about the early symptoms and signs. We have told these doctors that older age, diabetic, ICU admission, glucocorticoid therapy, you should be cautious. Next, in case of this, we need an early diagnosis in mucor. That is very important. And that's the way we try to train them. That is the very important factor. Aggressive surgical debridement is also very important. And cost of treatment is a serious challenge in Asian country because we have seen that a lot of patients, they could not complete their therapy. They have gone and they are coming back after having their intracranial involvement that is there. Thank you, friends. I invite you to this particular conference that would be happening next year. That is our 21st Congress of International Society for Human and Animal Mycology. It would be now during September 2024, during 2022. From me, John Perfect would take over as the president of this body. Thank you for your kind attention.
Thank you, Runalok. Again, this was pre-recorded, and our next speaker is also a recorded talk. This is to be given by Ashraf Ibrahim, who is a professor of medicine at the David Geffen School of Medicine at UCLA. He's also senior investigator and vice chair of the board of directors at the Los Angeles Biomedical Research Institute at Harbor, UCLA. He's going to talk to us today about GPR78 receptor and its possible links to COVID-associated mucormycosis. Thank you, Ashraf.
Hi, this is Ashraf Ibrahim. I would like to thank the organizers for inviting me to speak to you today about potential relationship between cell surface receptor, glucose-regulated protein, molecular weight 78, and mucormycosis in COVID-19 patients. So before I start, just a quick reminder about mucormycosis. It's a fungal infection. It's lethal in nature. It can be acquired by inhalation or ingestion. Inhalation by far is the most common route of infection that results mainly in two forms of disease, either rhino-orbital cerebral mucormycosis, mainly seen in diabetics and ketoacidosis, or pulmonary infection, mainly seen in hematologic malignancies patients. Cutaneous infection can also happen through direct inoculation into open wounds, such as seen either in military personnel subjected to improvised explosives or motorcycle accidents. The problem with mucormycosis, as we all know, the mortality is very high. Overall mortality is approximately 50%, and it can be up to 90 to 100% in certain categories of patients. Lately, mucormycosis in COVID-19 patients was highlighted in media outlets because of the outbreak that we've seen in many parts of the world, in particular in India, within a 2-month period between May to July of 2021. The official counts of mucormycosis or COVID-19 associated mucormycosis CAM were reported to be more than 47,000 cases. They were mainly seen in diabetics patients who are being treated with high doses of corticosteroids to treat basically the cytokine storm that results from COVID-19 infections. And it's mainly of the rhino-orbital cerebral mucormycosis. GRP78 is a heat shock protein, stress-related, usually overexpressed in certain situations such as infections, as well as in cancer cells. GRP78 is mainly a cytoplasmic protein, but under stress-related conditions, and when it is overexpressed, it can be relocalized to the cell surface of cells. There are actually several reports showing that GRP78 can act as a receptor to several viruses, including dengue, Zika viruses, and recently SARS-CoV-2 in their entry basically into the host cells. And as a result, there is a possibility that GRP78 acts as a receptor for COVID-19, and I'll show you some data to later on in the presentation. So when we started basically looking at GRP78 and the possibility of it being a receptor to mucormycosis, we basically conducted an in vitro assay to see if Rhizopus spores, being the most common cause of infection, can actually invade either nasal epithelial cells or lung epithelial cells, because we reasoned that this is basically the first line of interaction when the organism is being inhaled. And you can see here within short period of time with interacting with CCL30 cells, which are nasal epithelial cells, Rhizospus spores can actually invade really quickly. And within 6 hours, you have 100% invasion. And this invasion is not just basically the cells lying on the monolayers, but actually, as you can see here in the three-dimensional confocal microscopy, it's an actual penetration of the nasal cells. And that entry results also in death of the host cells, the nasal cells, in a time-dependent manner. Within 48 hours, you get approximately 80 to 90% of the cells being killed by using the chrome release assay. So with that being said, we were interested in trying to figure out what is the receptors involved in that entry into nasal cells. And what we did is we used basically an old technique developed by Eisberg and Leong, which is basically an affinity maturation or affinity purification, whereby you take the host cells, biotinylate them, and then extract their cell membranes, incubate the cell membranes, which are now biotinylated, with spores of Rhizospus. And then after a certain period of time, you extensively wash the end-bound cell, the end-bound proteins, and then you can elute the bound proteins by 6 molar urea, run them on a gel by SDS page, and by using antibiotic antibodies, you can actually detect certain bands that bound to the spores. And you can take those, basically cut them off the gel, sequence them, and you'll have an idea on what the protein of the cell membrane protein that bound to your organism. And what we found is when we incubated Rhizospus delamar, the most common protein that came out is basically at a molecular weight kilodalton, 78 kilodalton. And that was basically when we did the sequence was GRP78 protein. So what we did is you can see here the total membranes without being incubated Rhizospus are actually well biotinylated, which is really a good control. And there is this really distinct band here in Rhizospus. So if you take the same membrane and you strip it and then you blot it again with anti-GRP78, which is commercially available, you'll see that you can detect really the same band here again, indicating that this is basically what's bounding to the spores of Rhizospus delamar. And it seems that this is also not only specific to Rhizospus, but it's really a universal receptor to all Mucorales. You can see here you pull down the same band with a GRP78 binding to different Mucorales, as you can see here. We did the same thing with lung epithelial cells, and what we found is the major protein was not GRP78, but rather integrin beta-1 alpha-3. And then if you use the same technique by blotting the same membrane blotted with antibiotin with commercially available anti-integrin beta-1 antibodies, you basically detect the same band, indicating that this is probably the receptor for lung epithelial cells during invasion with Mucorales. And again, this is really a universal band showing with different clinical isolates of Mucorales. So to prove that the GRP78 is a receptor for nasal epithelial cells, we used both antibodies that we have commercially against GRP78 and anti-integrin antibodies. And we wanted to see whether these antibodies can block adhesion and invasion to nasal epithelial cells. And you can see here that anti-GRP78 was able to block invasion by approximately 50% to nasal epithelial cells, whereas anti-integrin beta-1 antibody didn't. There was no effect on adhesion. We believe that receptors mediating adhesion and invasion are totally different. These are two different processes. Usually initiates with adhesion. The organism rolls on, binds to another receptor, and that triggers invasion. And what we found is if you block invasion, you actually block the ability of the organism to damage the nasal epithelial cells as well. But only with anti-GRP78, and nothing really happens with anti-integrin beta-1 antibodies. Again, corroborating what we found with the affinity purification process, that the GRP78 is the receptor for nasal epithelial cells. We did the same thing with lung epithelial cells, And it's totally the opposite. You'll see that the anti-integrin beta-1 almost completely blocks invasion, whereas anti-GRP78 doesn't, again indicating that the receptor for lung epithelial cells is integrin beta-1 alpha-3. And again, you'll see basically if you block invasion, you really block the ability of the pathogen to cause damage. On the other side of the coin, we wanted to understand what's on the fungus binds to these receptors. So what we did, we used something called far western blotting, whereby you actually, if you know the receptor, you take your rhizopus, you protoplasm, and if you put them, regenerate, put them in an osmolytic stabilizer, such as sorbitol, and let them regenerate, they'll start sputing basically all cell wall material into the supernatant. You take the supernatant, concentrate it, run it on a non-denaturing gel, and then you come with your newly identified receptor, in this case GRP78 or integrin beta-1 alpha-3, and with the anti-integrin or anti-GRP78, you'll be able to pinpoint a certain band on the non-denaturing gel. You can take it, sequence it, and it will give you an idea about what fungal ligand binds to these receptors. What we found is with the nasal cells, COT-H3 bound to GRP78. We did the same thing with lung epithelial cells, and we found that it is COT-H7. So both of them, obviously, they belong to the same family of proteins. COT-H, in collaboration with Vinnie Bruno at University of Maryland, we were able to sequence 30 plus isolates of Mucorales. All of them are clinical isolates. And COT-H is a unique member of cell surface proteins, GPI anchor proteins, extremely expressed in Mucorales, whether spores or germlings. And they are really unique to Mucorales. You can't find them anywhere else, any fungi, bacteria, or any form of life, or even mammalian cells. And you can see here that these isolates here, all of them, they contain COT-H proteins ranging anywhere between 1 to 7 copies. And you can see that the last three these are Basidibolus and Candidibolus, which are really previously were classified as zygomyces, but they form a non-invasive disease, totally different to mucormycosis. And again, emphasizing the fact that these proteins are professional invasors. They allow the organism to invade host cells. So what we did is COT-H3 and COT-H7, they have a certain motif. That motif is predicted to be antigenic, as well as also residing in the binding facet of COT-H proteins to the receptors. So what we did is we raised antibodies against that peptide, and you can see that the identity here close to 70%. And we use these antibodies to see whether we can block invasion and damage to the host cells. And here, studying Rhizopus delamar with nasal epithelial cells in the presence of anti-COT-H antibodies, you can completely block invasion, more or less completely. And then you have more than 70 to 80% also prevention of Rhizopus-mediated damage to nasal epithelial cells. Same thing can be said for lung epithelial cells as well. So these antibodies seems to be protective, and we've shown in animal models that these antibodies are actually highly protective, and we currently know we have a humanized antibody that we are trying to develop for clinical trials. What I would like to also emphasize here is trying to understand why diabetics and ketoacidosis usually have a nasal or rhino-orbital disease, whereas lung with neutropenic have basically a lung disease. So we reason that in diabetics, in ketoacidosis in particular, there are certain host factors that organisms and cells are exposed to. These are hyperglycemia, obviously. There is also hyperglycemia and ketoacidosis cause what we call elevated available serum iron, because they compromise the ability of transferrin to bind iron very well. And as a result, you'll have basically free iron floating in the blood or in the serum. And this is now well documented that this iron actually causes a lot of problems in diabetics or who have poorly controlled diabetes. So what we did is we took concentrations that are physiologically present in these patients of glucose, iron, or BHB, or being a classic ketone bodies, beta hydroxybutyrate. And we studied the expression of GRP78 on nasal epithelial cells. And you can see as you increase the concentration of glucose from the normal 1 milligram per ml to 4 and 8, you have higher expression of GRP78 on the cell surface of these cells. Same thing can be said at 15 and 50 microgram per ml of iron, and BHB of millimolar 5 and 10 as well. It can be as high as 6-fold increase of GRP78. And that really translates into the ability of Rhizospus oryzae or Rhizospus telomer and others as well that I don't have the time to show you, to actually have enhanced invasion of these cells at these concentrations and a gradual increase, as you can see here. And also that translates on a higher or an increased ability of the fungus to cause damage to these cells as well. What we did is we also studied these factors on lung epithelial cells. Remember, the lung epithelial cells, they have actually integrin beta-1 alpha-3, and we just really couldn't see any enhancement of expression of GRP78 or integrin beta-1 alpha-3, or actually subsequent invasion and damage. So we came up with a model that explains why diabetics and ketoacidosis are predisposed to rhino-orbital disease rather than lung infection, whereby a person who is in diabetics, in poorly controlled diabetes, hyperglycemia, or in ketoacidosis, inhales spores as anybody else. And due to the fact that you have environmental factors or host factors such as hyperglycemia, elevated iron, and ketoacidosis, you have an enhanced expression of GRP78. That, as a result, basically traps the spores into the sinus, and that causes infection. So in other words, the spores that are inhaled never really gets all the way into the alveoli to cause pulmonary infection. Whereas it's totally the opposite in pulmonary infection. You really have no overexpression of GRP78 in the nasal cavity. As a result, inhaled spores get into the lungs, and they bind to integrin beta-1 and 3. And we know that integrin beta-1 and 3 activates the EGFR receptor or co-receptor, and that basically by phosphorylation, and that triggers the invasion process as well. So now, where does GRP78 as a receptor for COVID-19 comes in? So there was a publication shortly after the first wave that we've had in the US came out, I think in March of 2020, by using molecular docking analysis. They showed that cell surface GRP78, depicted here in green, is predicted to bind spike protein of COVID-19. And that was literally all done by molecular modeling. And then shortly after, in early 2021, this paper came from the lab of Amy Lee, who works really on GRP78 and its role in cancer cells. And she has an antibody, humanized antibody, that's actually developed to specifically block GRP78 in hopefully in treating cancer, several cancers, whereby GRP78 is implicated in promoting cancer cells or growth. And what they did is they're actually clever. They used epithelial cells that is overexpressing ACE2, human ACE2, which is, as you know, is the receptor or accepted receptor for spike protein. And they recombinantly expressed on those cells either a hemagglutinin spike protein or a flag protein GRP78. And you can see here in the whole cell lysate that these are really well expressed in spike protein GRP78. And by using immunoprecipitation, either by using an anti-hemagglutinin antibody, you actually detect the spike, as you would expect, because it is a hemagglutinin spike. But also in addition to this, even though that this is GRP78 is not hemagglutinin tagged, but you can pull it down. And the same thing can be said with the anti-flag as well. This indicates that there is some sort of an interaction between GRP78 and spike and the ACE2. And by using also antibodies incubated with lung epithelial cells prior to introducing a vesicular stomatitis virus, they were able to show that these antibodies, which are specific to GRP78, the humanized antibody, you can actually here block GRP78, as you would expect, from binding to ACE2. And as a result, it prevents the VSV virus pseudoparticles of binding to ACE2, and as a result, it prevents endocytosis. And presumably, and they haven't shown that this antibody would actually protect against COVID-19 infections, and this is yet to be seen. So how does this translate into mucormycosis, or CAM, or COVID-19 associated mucormycosis? There was another study that came also earlier this year showing that patients who suffer from COVID-19 pneumonia, depicted here in black, and there were 72 of them, they express what we call serum GRP78. In other words, probably cell surface GRP78, relocalized to the cell surface. When you compare it to patients who had signs of pneumonia, but they were negative for PCR tests for COVID-19, and also negative with pneumonia as depicted by X-rays, and also compared to normal people as well. So this increase in GRP78 is now a fact among patients who suffer from COVID-19, which is expected. This is, as we said, it's a heat shock protein overexpressed in stressful conditions, and there is really nothing more stressful than an infection, especially life-threatening infection. So it's a possibility that the GRP78 overexpressed might actually act as a receptor for patients who suffer from mucormycosis or CAM. But is it really the only reason or not? And then I'll get to that. So just to summarize, Ricebus invades nasal epithelial cells by CATH3 GRP78, and this interaction is really modulated by host factors present in diabetic ketoacidosis, such as hyperglycemia, elevated available serum iron, as well as ketone bodies, resulting in basically trapping the spores as they are being inhaled into the nasal cavity, causing rhinoorbital cerebral mucormycosis. Ricebus invades alveolar epithelial cells via CATH7 interacting with integrin beta-1, which triggers activation of the EGFR receptors in tissues and causing basically invasion and pulmonary mucormycosis. And this process is not regulated by DKA host factors. As in many viral infections, GRP78 is overexpressed in patients with COVID-19 and may act as an auxiliary receptor to the virus, mainly by binding to ACE2 and spike protein. We actually have done in the lab direct interaction between ACE2 and GRP78 by themselves, between GRP78 and spike protein by itself, and we couldn't really see much of interaction. It seems that the presence of ACE2 is necessary to show that there is some interaction between ACE2, GRP78, and spike protein. So again, the question is COVID-19 infection sufficient to cause mucormycosis infection through overexpression of GRP78? And to me, it is unlikely. And the reason for this, because this is not the only cause why those patients are suffering from mucormycosis. We know from the clinical data that patients who have COVID-19 and develop mucormycosis are usually treated with very high doses of corticosteroids to stem the tide of the hyper-inflammatory immune response triggered by COVID-19. So, and this basically doesn't really happen in those who are not treated with corticosteroids. So to me, I think in diabetics ketoacidosis, the presence of hyperglycemia or prolonged hyperglycemia even in the absence of ketoacidosis, is sufficient to cause infection or a risk factor to the extent that it overexpresses GRP78 to very high levels and causing infection, even if ketoacidosis is not present. If ketoacidosis is present, then you have even more expression of GRP78. And as a result, those patients become uniquely predisposed to mucormycosis. The other thing which also have to take in mind, there is also environmental factors. The burden of disease in India in particular has always been high. We knew that even prior to COVID-19. And there are studies by Chakrabarti and Prakash showing that the burden of disease is at least 70-fold higher than any other part of the world. India was predicted to have, through population-based studies, predicted to have approximately 200,000 cases of mucormycosis per year. And now we believe it because the 47,000 documented, or actually 48,000 documented cases within 2 months, 1/3 of those are non-COVID related, meaning that we have approximately 17,000 to 18,000 cases of mucormycosis in India that were reported within 2 to 3 months among non-COVID related patients as well. So lastly, I would like to finish by thanking people who have been involved in this line of research, including the two most important in this particular receptor work is particularly Girgis Ibrahim as well as Abdullah Karif. Abdullah is a PhD student who is working on the nasal and the lung epithelial cells, trying to understand what are the predisposing factors. Emily has been generous with us in providing her raw materials and important things that we use in our research for proving that GRP78 is actually a receptor for mucorales, both in nasal epithelial cells and also in endothelial cells during dissemination, metagenous dissemination. And finally, of course, the support from the Boris Wellcome Fund and the National Institutes of Health. So I'll stop here. Thank you so much.
Okay. Thank you, Ashraf. We're running about 5 minutes behind, so I want to move forward and go to the next talk and speaker. Our next speaker is Jeremy Walker. He's recently joined the faculty at UAB, former chief resident and ID fellow here, now doing transplant ID, infection prevention and stewardship in the transplant patient. And he's going to provide some tantalizing information about the potential relatedness between COVID and cryptococcal disease. So Jeremy, thanks for being here and look forward to your presentation.
Thank you so much for having me. It's really an honor to have this opportunity, and thanks in particular for Dr. Pappas for inviting me today. So I do want to talk about COVID-19 and Cryptococcus. I do not have any disclosures. And our objectives today are going to be to review some of the relevant background for this particular entity, as well as to discuss our initial case series from our institution. And so background, and this is things that I know many on this call know all too well, but cryptococcosis is caused as an invasive yeast infection, most predominantly by Cryptococcus neoformans, which is really kind of ubiquitous throughout the world. And more recently, significant reports with Cryptococcus gattii, which seems to be predominant in certain regions and is known to have increased virulence. It generally originates in the respiratory tract, but then can disseminate to many organ systems, but the one that we are the most concerned about is CNS involvement. And this has been really prominently described in patients who are immune suppressed with cell-mediated immunity, HIV, AIDS, and solid organ transplant, but of course can be seen even in patients who are presumably immune competent, although there's always some question about potentially underlying genetic risk factor or other disease presence. Within the solid organ transplant in particular, there is a concern for reactivation of quiescent infection, a concept that potentially there is a small amount of Cryptococcus that can then has the opportunity to reactivate and generally causes a more subacute presentation. The median time to onset in SOT is within that 1st to 2nd year post-transplant, so a higher immune suppressed period, but not the highest risk period that we tend to think of for opportunistic infections. And really in all populations, both solid organ transplant, even HIV, AIDS to an extent, and then particularly for our immune competent hosts, there is a long history of description of delayed diagnoses and many patients presenting with headaches for weeks to even at times a couple of months before a lumbar puncture is performed and the diagnosis is made and confirmed. As far as invasive fungal infections following viral pandemics, it's what we've been discussing today, and we've heard from many speakers who are much smarter than me and have a lot richer experience in this. But what we know is that Aspergillus in Canada have been well described by flu pandemics, and we've been hearing about how Aspergillus mucormycosis in Canada, as well as other fungal infections, have been seen post SARS-CoV-2. Multiple mechanisms involved with this, and of course I can't go through all of them, but a combination of the hyperinflammatory state with high cytokine storm, downregulation of cell-mediated immunity, breakdown of your mucociliary clearance system, and then, of course, the steroid use and other immune suppressive medications that we've been discussing. So I wanted to first start by reviewing what has been reported with Cryptococcus for these viral pandemics. So within influenza, there's actually only 4 isolated case reports that Fong et al. Actually put together in 2019 for us. All were in the setting of a pandemic flu, either H1N1 or H7N9. And in all of these patients, they were critically ill with influenza, admitted to an ICU, and during that primary admission developed Cryptococcus diagnosed by culture data. These patients had a high mortality rate, 3 of 4 died, and a high rate of CNS involvement. This is, of course, a very critically ill population to begin with because of the influenza, but none had any traditional predisposing risk factors or immune compromising conditions. This is a list of the 6 isolated case reports that I could find in the literature of cryptococcosis following COVID-19. I updated this over the weekend. It is limited to English language. I know there's at least one that I'm missing because of that limitation. But what you'll see here is, again, many of these patients are older with some comorbidities, but only one in the traditionally more high-risk patient population with a deceased donor kidney transplant, a few that had diabetes that is also a known risk factor for cryptococcal disease. But these were all, again, critically ill patients with COVID. So most required mechanical ventilation, all required ICU stay. All were in their index hospitalization with COVID or had just discharged to a facility when the symptoms and diagnosis of Cryptococcus occurred. And you can see that happen anywhere from 2 weeks post SARS-CoV-2 to 10. Most were disseminated. All of these were proved by culture. You can see 3 were blood cultures and 2 actually had evidence of CNS involvement. And again, here in this patient population that began by being critically ill by COVID, but then complicated by Cryptococcus, a very high mortality rate. So 5 of them died, and the one that survived required a BP shot and a prolonged hospitalization following, so a very complicated course. So that leads us in really to a description of our cases, which was presented earlier in ID Week poster, and so that can be referenced as well. And I included at the end of the slides for those who are interested as they're shared. But our case details are a little bit different. So these cases were all seen at our institution. We have a small group of transplant ID providers and a weekly case conference. And it was in that conference that this kind of recognition of a pattern in a couple of patients emerged that led us to go back and look through all the patients with a diagnosis of Cryptococcus that we had seen since SARS-CoV-2 began, and look at the timeline between SARS-CoV-2 diagnosis and cryptococcal disease. And from that, we've identified 6 patients that are documented here. We've actually had even a couple other reports come in since that time from other providers we've shared this information with. You see that these are traditionally immune suppressed patients. So one with simultaneous liver kidney transplant, one with simultaneous kidney pancreas, 2 deceased donor kidney transplants, 1 with a heart transplant, and then 1 who was on chronic methotrexate for an inflammatory uveitis. But all of these immune suppression regimens were stable. There have not been any recent changes. The one patient number 1, which we'll talk about, was within their first year post-transplant. So they were in the highest level of immune suppression, but their regimen had actually been tailored down to their stable dosing. What is also unique about these patients is they actually, none of them had a COVID diagnosis requiring ICU level care. 2 of these patients were actually managed outpatient with supportive care only. They did not even have steroids as part of their home regimen and did not get a course of steroids. The ones that were admitted were primarily admitted for remdesivir or for close monitoring on dexamethasone, but none, again, required mechanical ventilation or ICU level support, and all had discharged home before cryptococcal diagnosis was made. 3 of these patients did present with CNS symptoms, and we'll talk a little bit more about that on the next slide. 2 presented with more respiratory symptoms consistent with pulmonary involvement, and 1 had evidence of a cellulitis. The patients that had CNS involvement actually were very complicated, and so 1 required a VP shunt, 1 was complicated by multiple strokes, which has been described with cryptococcosis, and then the final 1 had what was truly an immune reconstitution syndrome response that developed after their initial line of treatment, which again has been described in our transplant population. But all of them are doing well, or at least stable at follow-up with some improvement. There was no mortality in this population. So a very different looking group than what we looked at as been reported in the literature previously. And so this is a slide I'll orient you to. This is at the bottom here is when the SARS-CoV diagnosis was made, and you can see it following out from there. The line would represent when the best we can outline from the patient's story, the symptoms kind of began, with the box representing the actual time of cryptococcus diagnosis. And then we'll talk a little bit about these as we go through. So the first patient, which was the one that was closest post-transplant, actually had just presented to clinic for a routine follow-up appointment, a fairly stoic lady, and had just said that she felt a little short of breath, but actually ended up having O2 sats in the mid-80s. And so she got admitted and worked up, and both results came back at the same time, a high positive crypto antigen, as well as a SARS-CoV-2 PCR-based test that was positive. Her imaging was consistent actually with both. She had a nodular component that was more consistent with cryptococcus, but then a diffuse kind of viral interstitial pattern that would be consistent with SARS-CoV-2. And she responded to treatment for both inpatient for a period and then eventually discharged home. The next 2 patients both presented within a month of SARS-CoV-2 diagnosis. They both had more disseminated symptoms. One had respiratory, the other had the cellulitis, both had fevers that were not responding to antibiotics, and both of those ended up having positive blood cultures for cryptococcus. And then the final 3 all developed symptoms more closely related to the SARS-CoV-2 diagnosis between that day 40 and day 75, but had delays in diagnosis going up until almost 12 weeks post SARS-CoV-2 diagnosis. And for especially these 2 in particular, if you read through the chart, much of that delay was because of attribution to long COVID syndrome. So the patient had fatigue, headaches, nausea, and those were attributed to that rather than to the cryptococcal infection that was eventually diagnosed. All of them grew cryptococcus from blood cultures, and all were treated with induction therapy. I will note that all of these cases are with Cryptococcus neoformans. All of these cases actually occurred earlier in, at least the SARS-CoV-2 occurred earlier in the pandemic, or at least before the most recent Delta wave variant came through. And all of these occurred before vaccination and monoclonal antibodies, at least that patient was able to receive. So I want to highlight patient 4 because I think that particularly tells the most interesting story. So this was a 62-year-old gentleman with a heart transplant, had been on stable immune suppression though for a long time, actually had known history of cryptococcal meningitis back in 2013 requiring a VP shunt. And he had completed 18 months of total therapy at that time, had followed in clinic regularly. Decision was made to discontinue appropriate with kind of our general treatment course. And he had done well off therapy since 2015. He was one of the two that had a very mild COVID in the winter of 2020, just some upper respiratory symptoms, was diagnosed by PCR as an outpatient, was treated really with supportive care only, did not even receive steroids. And then he was one that was readmitted later post SARS-CoV-2, but again had a 40-day lead-in period where he was having headaches and other symptoms, but there was just a delay in diagnosis, in part because of his being from a more rural area and not easily able to follow up at the transplant center. And again, with positive blood cultures and CNS cultures for Cryptococcus neoformans. He responded well to induction, but did require another VP shunt for his pressure management. And so, and really, I think here what we can make is observations. We're really limited in what we can say. We just have 6 patients that we're able to present, but there really does appear to be a temporal relationship between SARS-CoV-2 and the cryptococcal presentation in these patients. And these are all patients that are immune compromised that do have other risk factors for Cryptococcus, but as we see, the timing does seem to follow the timing that we would expect as far as how the disease propagates from the lungs, disseminating into the bloodstream, and then eventually into CNS. And the delay between diagnosis that we see kind of correlates with that. I think the other thing that's telling is the patient that we just reviewed, a patient who had been well controlled for several years off therapy and then had reactivation of disease after the SARS-CoV-2 diagnosis. We also see these are patients presenting that really had mild COVID, some of them not even requiring hospitalization, as compared to some of the patients that have been described in other places in the literature, but they had a different time course as well. Their progression of cryptococcal disease followed a more subacute kind of timeline, much more consistent with what we typically see with Cryptococcus, rather than the more fulminant courses described in those isolated case reports for patients who are critically ill in the ICU with other things. They were complicated infections, particularly those with CNS involvement, but our population compared to the other 2 groups I described, there was no mortality, which is significant. And then there's also the commentary around the delays in diagnosis and the attribution to long COVID syndrome that I think is a very important thing to remember, particularly for those who are caring for patients who have other underlying immunologic deficiencies that may predispose them to Cryptococcus beyond this. And another reason that we really need to investigate this further. And so really the next steps is to try to get more data so that we can better characterize this and really know if there is something to this pattern that we're seeing. And so the MSG ERC is helping us to coordinate a call for cases. We have a case report form developed and are working with our IRB. We are defining this as really a cryptococcal infection that's been confirmed either by antigen or presumed by cryptococcal antigen testing or confirmed by positive culture data with symptoms that began within 90 days of the SARS-CoV-2 infection. And the period that we're looking at is really March 2020 through October 2021. And we would just please contact if you have any cases that you would like to contribute as soon as we're able to actually open that up to receive those cases through survey, we will. As I close, I just want to acknowledge the many people who have supported me in this, most notably Dr. Pappas, who's here, but also Carolyn Jones, Rachel, and the whole study team who has helped us, as well as several of the fellows who helped me put together these cases. And then, as I said, my last slide for those who want to look at them when they're shared does have that poster as well, if desired. Thank you so much.
Thank you, Jeremy. To answer a quick question from one of the in the chat box, yes, they were all Cryptococcus neoformans. We'll get back to these questions at the end of this session, and but right now I'd like to move on to our last speaker, who will give a brief talk on COVID-19 and endemic fungi. This is George Thompson, GR. He's a professor of medicine at UC Davis in the Division of Infectious Diseases and also the fellowship director. I think his emphasis will probably be mostly on Cocci and COVID association, and perhaps touch on other areas where it is relevant. GR, thanks for being here.
Yeah, great. Thanks so much. Can you all hear me okay?
Yep, and see your slides.
Well, great. So thanks again to the organizing committee. It's really a pleasure to be here and talk about COVID-19 and the endemic mycoses, and really some of the issues that have come up for us during sort of the dual pandemics that are ongoing, at least for us that see a lot of cocci. So the key questions for us really to talk about, just to kind of go through these, COVID-19 and the association with endemic mycoses, that was really a nice introduction about Cryptococcus in the prior talk. And this is going to be fairly similar, but with a few little wrinkles that really come up in the care for us. There's clearly overlapping risk factors for both diseases, both COVID-19 and particularly Coccidioidomycoses, which we'll get into in a few slides. And the overlapping clinical presentations, particularly for mild or moderate COVID, that's really a diagnostic dilemma for us, at least for the first day while they're in the hospital. Unique risks for relapse will really be the focus of this talk. There's clearly transient immunologic defects associated with COVID-19. You know, we see Aspergillus cases, we see Mucormycosis cases, so we'll get into that just a bit. And then what impact do the treatments we're giving our COVID-19 patients have on Coccidioidomycosis or even relapse of disease? A little bit on some stuff we've been doing in the lab with diagnosis and monitoring and metabolomic signatures. And then how do we really counsel and what recommendations do we have for our patients? So real briefly, just I think we all know the life cycle of these different endemic mycoses, and we're really just going to focus on the first three: histoplasma, blastomyces, and Coccidioidomycosis. So these are all environmental molds. They're in the soil. They require exposure, of course, for infection. So whether that's histoplasma, arthrocanidia from Coccidioides, or blastomyces, these require inhalation in the lung. They either cause pneumonia or really no symptoms for the vast majority of patients exposed, but they do unfortunately disseminate for some of these patients, and then at that time encounter the healthcare system. So this is a little bit US focused talk since these fungi primarily are within the United States, and a few I saw Elon's on here, so blastomyces certainly in Canada as well. But this will be a little bit US centric just because Coccidioidomycosis, most of the cases really are in California and Arizona. So the overlapping risk factors with COVID, you can see here, really the groups that primarily are at risk for both either Coccidioidomycosis or COVID-19 are largely occupational, so construction workers and largely agricultural practices. And you can see here why a soil-dwelling organism would be very difficult to avoid within the agricultural environment. These spores are actually thrown several miles frequently during agricultural processes. And then we've really dealt with the wildfires here in California the last few years, and we actually think those are responsible for throwing these organisms up potentially into the jet stream and then blowing these different spores really throughout the country. There's been some cases of Coccidioides as far to the east as Missouri, where it's not endemic. So how it got there is still a little bit of a question mark. The incarcerated populations really have a very difficult time with both of these infections. There's been lots of outbreaks of COVID-19 within the California prison system. A lot of the prisons are within the Central Valley, where most of the Coccidioides cases are seen. There's very dry land in that area, certainly. So with any wind, it's going to cause these spores to become airborne. So outbreaks of both COVID-19 and Coccidioidomycosis are seen within the California prison system. And then race, certainly with disparities, I think that's been really well presented in a number of recent publications, the risks certainly for COVID-19 in different populations. And then our Filipino and African-American patients really do have a heightened risk of severe Coccidioidomycosis for genetic reasons that Steve Holland and Amy Sue have really identified in conjunction with others. And then dust exposure. So particulate matter that's of 2.5 micron or 10 micron size really leads to both respiratory viral infections such as COVID and Coccidioidomycosis. And it's a little unclear if these different viral or fungal pathogens ride on this particulate matter, or if the particulate matter causes epithelial injury within the lung that later predisposes to infection. But you can see these really are overlapping risk factors for Coccidioidomycosis and COVID-19 that do cause some problems for our patients, certainly. So not only overlapping risk factors, but they do often have a similar clinical presentation. So if you presented one of these patients on rounds that came into the ER with upper respiratory symptoms, a dry cough, myalgias or arthralgias, a headache, fever, rash, and malaise, right now, we would have a little bit of a tough time without any other information knowing is that COVID-19, is that Coccidioidomycosis. And the chest X-ray really is not going to tell the difference either. You can see this lower left infiltrate here. And it really depends on the pretest probability of COVID-19 or coccidioidomycosis. And where we practice, between 17 and 24% of all community-acquired pneumonia is actually due to coccidioidomycosis in the Central Valley. So it's truly endemic. So to overlay that with a pandemic of COVID-19, there's really going to be a lot of patients that could have one or the other or potentially both. And that's really what we have been dealing with is patients who've had prior cocci and then coming with COVID. That's been a big complication, we think. So there's clearly been sociologic factors that have impacted certainly the epidemic aspect of coccidioidomycosis that we have dealt with. The stay-at-home order, masking. These are not N95 masks that most of the people in the community are using, but what about cloth masks, surgical masks? What's the impact that's had on coccidioidomycosis incidence? And then certainly less travel, less enjoyment of hobbies, all these things may decrease exposure to coccidioidomycosis as well. And then here's really some early data from the California Department of Health. This is not on their website quite yet, but it includes both California and Arizona cases. And you can see here, if you look just at California, which is blue, really since 2001, you can see our numbers actually are slightly down from 2019. And this is really thought to be from some of those sociologic factors. So less travel, less large-scale exposure. The use of masks probably played some role in reducing the number of coccidioidomycosis cases. But Arizona, you can see, continued to increase from 2019. So that's really pretty interesting. Despite this small number, this is maybe 20,000 cases that have been reported for 2020. You have to remember, reported cases are a small minority of actual total cases. A lot of patients with coccidioidomycosis will not ever have a formal diagnosis. They'll cough or not feel well for several weeks, and the disease, for the vast majority of people, is going to self-resolve. And so that's what you see. So the true number of cases, it's thought to be about 150,000 cases a year. The CDC has an ongoing effort right now to update that number with several different modeling parameters. So if you take this 150,000 people and maybe we'll multiply it by 2 years for 2020 and 2021, have 300,000 people, and somewhere between 10 and 20% of those patients are going to have COVID, naturally acquired infection. That's a lot of patients that have had both coccidioidomycosis and COVID-19. So one of the problems we run into is, just to back up just a little bit, so this would be just for coccidioidomycosis, but certainly happens in histoplasma, in blastomyces, and even in Cryptococcus, is as this pneumonia sort of heals, it can form a coin lesion or a nodule. And that's certainly seen on CAT scan here. So there's a peripheral nodule here. This is benign. This is old fungal disease that's been walled off. It's very similar to tuberculosis with granuloma formation. But it causes a lot of problems during clinical care. Is this lung cancer? Is this old endemic mycoses? And really to zoom in just a little bit on that and to borrow from our colleagues in tuberculosis, when these patients form a granuloma, this is an active process, of course, right? So there's local infection at the site, release of pro-inflammatory mediators, and you have a resolved granuloma. But really how we view a resolved granuloma, I think has been a little bit, at least was taught to me wrongly. And this is a really nice paper by the group out of University of Washington that used a replication clock to look at plasmid loss over time in tuberculosis to actually see how much of this organism in a granuloma continues to replicate. Because I think wrongly we have thought tuberculosis and certainly fungal pathogens in a granuloma are inert or completely quiescent and there's no turnover, and that's not really correct. So we know that they turn over time, and with that you have continued antigen exposure to sort of the granuloma cell wall. So with any loss of immunologic control, either through loss of CD4 cells, interferon gamma, TNF alpha, a granuloma can easily rupture and the infection recur. And that's really the big risk that we have seen with these coccidioidomycosis patients. They've got well-formed granulomas over their body for a number of years. And with a hit to their immune system, the granulomas can sort of open back up and the infection relapse. So this low-grade replication, again, we do think causes repeated antigenic exposure. For our coccidioidomycosis patients, we've seen that even pre-COVID, where we think their granulomas rupture and they get sort of a serologic relapse before ultimate recontrol of the disease. But during COVID, we do think this is a potential hit on their immune system that can lead to relapse of their coccidioidomycosis. So we do know that these granulomas are active when they're resected. They're often culture positive, so it is active in live coccidioides. So what's the total number of patients at risk? So I mentioned So about 150,000 people a year are infected, but what's the cumulative population for those who have had cocci at some point in their life? And this is really difficult to discern. So there had previously been a skin test for coccidioides, and these are older studies, obviously 1930s and then 1983, not quite as old, but found rates of positive skin tests within the endemic region with tremendous variability. So between 4 and 10% in Kern County, California, which is where Bakersfield is, and then Maricopa County, which is Phoenix, 21%. And you can see from these different studies in some of the modeling that they've done, if you've lived in the area for 50 years, one of these studies thought you've got about 100% chance of prior cocci. Some of the others quite a bit lower, between 40 and 70%. And we really can't replicate these studies now. So the current skin test reagent is Spherusol, which is made a little different than the prior skin testing reagents. It looks like it's probably not as sensitive, misses some of the patients who've known to have cocci. But in the 37,000 prisoners who were tested within the California prison system, the rate of positivity for them was about 8%. So that's still a tremendous number of people within California and Arizona that have had coccidioidomycosis at some point in their life, whether they were formally diagnosed or not. So where are these different locations? So you can see Kern County, which is located down here, really makes up the brunt of the cases of coccidioidomycosis, followed by several of the others within the southern San Joaquin Valley region. And I've overlaid this here with the number of COVID-19 cases they have per 100,000, because these 3 different counties with the highest rates really also have some of the highest rates of COVID-19 that we've seen in California. And some folks out of UC Berkeley actually put together this sort of graphical analysis here to graph COVID-19 cases compared to cocci cases. So you can see Kern County here at the top, and then some of these are Indian reservations within Arizona, and then also Kings County, California here. So really these overlapping epidemics of COVID-19 and coccidioidomycosis have put a lot of people within these different regions at risk. So what do I mean by risk? So I think that, certainly in Tom Patterson's talked about the different risk factors and immunosuppressive effects of COVID-19. The therapy we give for COVID-19 is highly immunosuppressive corticosteroids or other immunomodulatory agents. They do develop leukopenia and lymphopenia, immune dysregulation, which I think is a bit of a wastebasket term, structural lung disease from the fibrosis with COVID-19, and then prior antibiotics may change the microbiome just a little bit. But if you really dig through some of these different immunology papers, they do have a decline in their CD4 count. And actually this Frontiers paper here graphed what they think is the decrease in the CD4 count over time with mild COVID here, and compared it to acute HIV infection. So you can see they do have a precipitous drop in their CD4 count from normal to maybe in the 600s. And then with severe COVID, like we see in our ICU patients, it can be quite low, as you see here. So I thought this was really a pretty interesting paper. The reasons for that are a little bit unclear, at least to me. The authors of those different papers have speculated that COVID-19 directly infects lymphocytes. Also, certainly with any sepsis or immune response, you're going to get T-cell exhaustion, apoptosis, and certainly decreased production of different CD4 and CD8 cells. So I think together this may potentially delineate the major risk factor for recurrence of endemic mycoses following COVID-19. I think that this loss of CD4 cells is sort of what leads to loss of control of those different granulomas that we have seen. So to study this, we've really tried to pull all of our patients who've had a known diagnosis of coccidioidomycosis and a known diagnosis of COVID-19. And obviously that's going to miss a lot of people who were either never diagnosed or have been lost to follow-up. But this was really just a case control study to look at those who had coccidioidomycosis and relapsed after COVID-19 versus those who did not relapse over COVID-19. And really, we didn't find any difference between groups at all, except for the time of their initial diagnosis of coccidioidomycosis. So if they had a recent diagnosis of coccidioidomycosis, they were much more likely to relapse after COVID-19 than those who had cocci in the distant past. So the differences in time there were 9.3 months in those who relapsed versus 27.7 months in those who did not relapse. This is very limited. We've had a fairly low number of patients that had truly diagnosed relapse disease. Again, I think we've missed a lot of these. No differences in age, comorbidities, receipt of antifungal therapy. But really, this is a group that has not had a lot of comorbidities, at least when we look through their charts. Diagnosis of cocci was quite recent for most of these, all within 2-year time frame. All of these were off antifungal therapy at the time of relapse. A lot of these did have a bit of residual disease, which a cavity or nodule, when imaged at the end of their antifungal therapy. And they all had a serologic increase in addition to their symptoms, all treated and all had clinical resolution. Well, so one of the problems with this is when we've taken blood samples from all of these patients from some metabolomics work that we've done, and we've been focused on this for a couple of years, actually, even pre-COVID-19, and found that really the metabolomics were helpful diagnostically to differentiate patients with a respiratory infection from a non-cocci illness versus cocci or valley fever. You can see the metabolomics profiles are clearly able to delineate healthy patients with other etiologies of their respiratory illness versus coccidioidomycosis. So then we took this group that had coccidioidomycosis to see if the metabolomics could also stratify them by meningitis, which is sort of this red oval, versus non-meningitis, which is this orange sort of oval. There's just a bit of overlap, certainly, but you can see here they're clearly different groups by metabolomic data. Well, from this, that's sort of helpful. We can tease apart maybe even who's going to disseminate and develop meningitis. But we took this group of patients that had meningitis or disseminated coccidioidomycosis, which is this red column here, and then this blue column is basically those who did not disseminate. And then we took our patients who had a history of cocci and had relapsed following COVID, and you can see their metabolomic profile actually switched to the same as those with disseminated disease. And that's different than patients who had COVID alone and no history of cocci. So I can't show you all the data. My collaborators weren't real crazy about that, but this is in press. But you can see it really switches a lot of the immune markers of metabolomic profile to more of a disseminated picture. So we do think that probably most of these patients are going to need antifungal therapy while your immune response returns to normal. This is going to need a lot more follow-up work. We're fairly excited about this. One of them is actually a novel immunologic pathway that we think may actually be provoked by COVID-19. So this may really predispose a lot of these patients to symptomatic relapse and hopefully not dissemination, but that really has been seen in one of these patients that was published in Military Medicine, which was an accelerated progression of disseminated cocci following COVID-19. So this was published by the US Navy. This is a 23-year-old African-American male, had mild COVID while aboard the USS Theodore Roosevelt. That was a well-described outbreak early in the epidemic. And this patient did not have any specific medical care for his COVID-19. He did very well with just symptomatic treatment. But 30 days after COVID-19, he developed fever, chills, and night sweats, had new skin lesions. And you can see here a PET CT showed spinal lesions as well, developed generalized lymphadenopathy and lung lesions, was ultimately diagnosed with coccidioidomycosis on a biopsy. So a 30-day time frame to go from asymptomatic to skin lesions and disseminated cocci is very rapid for those of you who don't see a lot of coccidioidomycosis. So I think that does take a bit of speculation to see that COVID-19 pushed the disease that quickly, but I think in line with some of the metabolomics data that we have seen, it makes a lot of sense pathophysiologically as well. So that's kind of the end of the story for cocci, and I'm very biased. That's what we see the most of here. But to look through the literature for the other endemic mycoses, there's really not much that's been reported. There's been, I think, 6 cases of histo now. There's been 4 cases here that we're going to talk about. These all had HIV, had active histoplasmosis. COVID-19 was incidentally found in these patients. It really didn't appear to impact their treatment of histoplasma at all. These patients were already on antifungal therapy for histoplasma, though, so I think that likely played a significant role in decreasing any of the potential morbidity from concurrent infection. And then I'm only able to find 1 reported case of blastomyces in association with COVID-19. And this patient had severe COVID-19 postpartum, required ECMO. They really didn't turn around quite in the fashion that the treating physicians thought that they should. They actually found reactivation of blastomyces in this patient. The treatment was not delineated. This is a poster presentation at CHEST, and the patient did survive to a skilled nursing facility at discharge, but really not a lot of details provided. Not able to find any reports about sporothrix, emergomyces, taloromyces, or paracoccidioides looking through literature. So I think we would be very interested in how those patients have done with concurrent COVID-19. I think that would really help us fill in some of the details in this story, but we just don't have any of the data for that quite yet. So in conclusion, for some of these patients with COVID-19 or cocci, certainly within an endemic region, overlapping risk factors are really going to be difficult to sort through early in their presentation. They do have similar clinical symptoms at times. We do think that COVID-19 induced immunosuppression leads to relapse of infection from these granulomas. Novel pathways really may heighten their risk for this, and really a high index of suspicion is required for diagnosis. And with that, I'll thank you so much for your attention and listening today. Thanks to Gail Cooksey for providing some of the data really ahead of time for the number of Cocci cases in California and Arizona. And then thanks to our collaborators here for some of the metabolomics work. And then you can see here, this is what's called a haboob, sort of a windstorm where it picks up massive amounts of dust and then dumps them on cities throughout Arizona or the Central Valley in California, which is why so many of these patients develop coccidioidomycosis. But with that, I'm certainly happy to answer any questions. And thanks again for your time.
Thanks, GR. And we don't have time for questions. We'll, if we have time at the end of this, we'll pick up some of these. I was wrong when I said that GR was the last. I knew that Megan Lyman is kind of going to wrap this up with her talk on Canada. I just wanted to see if she was awake and maybe get her blood pressure going up a little bit. Anyway, Megan, really looking forward to this because I think you've got maybe the broadest view perhaps of these complications in a contemporaneous fashion. So we're looking forward to your comments on COVID-associated candidiasis. And with that, and Megan is works in the mycology branch at CDC along with Tom, and has been a great partner in all this. Thank you, Megan.
You're muted, Megan.
There
Can
you
you
go.
hear me now?
Yes,
All right,
we can hear you now.
perfect. All right.
Perfect.
I guess I was falling asleep. So thanks for having me to talk about the impact that we've seen of COVID-19 on Candida. So I'm going to be talking about Candidemia and Candida auris. So thanks to everyone for sticking around to the end, and I'll try and keep it on the high points. So first, I'm going to start off with Candidemia. So in addition to co-infections of COVID-19 and Aspergillosis or Mucormycosis, there have been an increasing number of reports about co-infections with COVID-19 and Candidemia. But these have been, had limited sample size and geographic scope, and all just include one, maybe two hospitals, and maybe have just a handful of cases. So we thought this was a great opportunity for us to investigate how Candidemia may have been impacted using CDC's Candidemia surveillance through the Emerging Infections Program, which is an active population-based surveillance system of culture-confirmed Candida found in blood specimens among sites in 10 states, which you can see are pictured here. So last summer, we added questions to collect information related to COVID. So I'll describe a bit of our findings, which were published several months ago. And at the time of this analysis, there were information about 251 Candidemia cases from 8 surveillance sites, and 25% of those had tested positive for COVID-19 in the 30 days prior to Candidemia. Many of the underlying conditions were more common among those without COVID, including conditions commonly associated with Candidemia like malignancy or liver disease, while other conditions like diabetes or obesity, which are risk factors for severe COVID-19, were perhaps not surprisingly more common among those with COVID. But we are very interested in healthcare risk factors. Most cases with COVID-19 were healthcare onset, while a greater proportion of cases without COVID were community onset or healthcare associated community onset. And related to this, cases with COVID-19 in blue were being diagnosed with Candidemia longer after admission, while cases without COVID-19 in red were diagnosed sooner after admission. And looking at specific healthcare exposures, prior surgery and prior hospitalization were more common among those without COVID, while cases with COVID were more likely to have more high acuity healthcare exposures like ICU admission, mechanical ventilation, renal replacement, and central lines. And looking at immunosuppressive medications, systemic corticosteroids were twice as common in patients with COVID and were used for COVID treatment in more than 80% of those cases. And the IL-6 inhibitor, tocilizumab, was also more common in COVID patients and only used in those cases for COVID treatment. We found that candidemia cases with COVID-19 had worse outcomes. They were more likely to end up in the ICU. They had longer hospital stays and had double the case fatality. So overall, we found that patients with COVID-19 who developed candidemia were less likely to have typical underlying conditions and instead had more acute exposures related to their COVID-19 management. They really seemed much healthier until becoming acutely ill because of COVID-19. But our analysis was based on a convenient sample of cases available at the time, and we're looking forward to finalizing data for all the cases to evaluate changes in overall incidence. So next, I'm going to talk about the impact on Candida auris. And as you can see, there's been a lot of media attention on Candida auris during the pandemic, and I'll talk a little bit about what we've seen and both the direct and indirect impact of COVID on the spread. Tom mentioned all of these challenges for Candida auris surveillance earlier, but I did want to focus on the last one, the decrease in screening, because screening is so important to identify individuals who are asymptomatically colonized with Candida auris, but can still shed it into their environment and spread it to others. And here's a graph showing the volume of colonization screening conducted by CDC's antibiotic resistance lab network. And you can see there was a dramatic dip in screening around the start of the pandemic. The volume of screening has been increasing since then, especially after we saw evidence of transmission in some new geographic areas that prompted widespread screening. And despite this rise, there are still areas with a high burden of C. auris that have also been heavily impacted by COVID, where the amount of screening is still far below the pre-pandemic rates. And because of these challenges with screening, we've been encouraging species identification of all Candida specimens from any body sites to pick up as many cases as possible just through clinical specimens. And the number of cases of Candida auris has been steadily increasing since it was first reported in the US in 2016. And you can see this is true for both clinical and screening cases. And clinical cases are ones where the specimen was collected as part of routine clinical care, not necessarily invasive specimens. And screening cases are ones where C. auris was detected through colonization screening by swabbing the skin. And many of the earliest cases were introduced from abroad, but the majority of cases now are the result of local transmission. And you can see there was a slight dip in cases at the beginning of the pandemic. Again, this was likely related to decreased screening when the entire healthcare system was strained and preoccupied with COVID. So it really does mimic the trends you saw earlier in screening volume. But the number of clinical and screening cases has subsequently increased to levels higher than we've ever seen, and often in new areas. But even in areas that had controlled transmission of Candida auris, we've observed outbreaks, including in hospitals where we have not typically seen as much transmission compared to long-term care facilities like nursing homes. Many of these outbreaks were on COVID units and were likely related to changes in routine infection control practices, like using PPE conservation strategies. But even this is likely still an underestimate because of the challenges I mentioned in surveillance and decreased screening. And another sign that there's more undetected cases in transmission is that we're seeing cases without links to known cases or healthcare abroad. One example of a large outbreak on a COVID unit of a hospital that had previously had cases without experiencing much transmission. Half of the patients screened on this unit were positive, some of which later had clinical specimens that were positive. And on investigation, healthcare workers on this unit were wearing multiple layers of gowns and gloves and using the base layer for multiple patients. So they had many opportunities to contaminate this base layer and then spread CRS across the ward. And the healthcare workers were understandably afraid of becoming infected from COVID and were trying to use extra PPE to protect themselves, but may not have realized the risks associated with these different practices that they were implementing. You can also see that the geographic spread and number of states with cases has increased over time. And this is a map showing cases over the past year. I guess it's ends in May, but you can see that the most affected areas are currently New York, New Jersey, Illinois, California, and Florida more recently. But you can see that it started to creep into nearby states as patients move around and cross state lines. And this map is at the state level, but not all parts of each state are equally affected. Sometimes there are pockets of CRS in certain areas of the state, but it can obviously easily spread to new areas within that state or nearby states. We've also seen increased resistance. Before 2020, there were only 4 cases of pan-resistant CRS reported in the US. And these 4 cases had no epilinks to each other, and they all developed a echinocandin resistance on treatment, likely related to antifungal pressure. Additional testing didn't detect resistance among any healthcare contacts that were screened or environmental samples to suggest that this type of resistant strain was being spread. And there was some thought that resistance may be associated with a fitness cost that was maybe preventing it from spreading so easily. But we recently identified 2 independent clusters of pan-resistant or echinocandin-resistant cases among patients at the same facility who had not had prior echinocandin use. And this was the first evidence suggesting that this type of resistance might be spread. And these findings really highlighted the importance of susceptibility testing to identify resistance, especially in patients needing treatment for clinical infections or those not responding to treatment. And obviously these infections are really concerning because they're resistant to the first line treatment echinocandins, considering the high level of fluconazole resistance or azole resistance. And, you know, for many of these that are resistant to all 3 classes, treatment options are extremely limited. And through visits to facilities there during the pandemic, we identified some common gaps in key infection control practices that may contribute to spread of CRS. Some of these practices were related to COVID, and others might have just reflected poor baseline practices. So for hand hygiene, we found that many facilities were not aware that alcohol-based hand sanitizer was preferred over soap and water, in addition to missed opportunities for hand hygiene and limited access to supplies like hand sanitizer. For transmission-based precautions and use of PPE, facilities, as I mentioned, were inappropriately using double gowns and gloves that increased self-contamination. They were also reusing gowns and not changing PPE between patients, especially those in the same room. So after observing that gap and hearing that facilities were using conservation strategies, even when supplies like PPE were available, CDC changed their guidance to encourage facilities to use conventional and contingent strategies when possible, and only use crisis strategies when absolutely necessary. We also found that cohorting practices often were only focused on COVID and ignored other multi-drug resistant organisms, or were really complicated and resulted in frequent and unnecessary patient movement and more frequent exposures for other patients. And there have continued to be gaps in communication of Candida auris status and other MDRO status between facilities and health departments, which is really important to prevent spread and allow appropriate containment measures and infection control precautions. And environmental cleaning and disinfection is so important because Candida auris is shed into the healthcare environment and can persist for a very long time. But we observed inadequate preparation of bleach, insufficient cleaning of high-touch surfaces, and mobile medical equipment. And many common healthcare disinfectants are not effective against Candida auris, especially products with only quaternary ammonium compounds. But EPA just established a list of products tested and approved for Candida auris called List P. And the good news is that all List P disinfectants are also effective against COVID. But if List P products are not available, List K products are still should be effective against C. auris as well. So we have lots of information on our website and updates about Candida and Candida auris. So I will end there, and thank you.
Megan, thank you. Thank you for the really nice update. I think a lot of us who don't live in Candida auris endemic areas are not that aware of it. But anyway, this is really helpful. Okay, we're going to switch gears, and I'm going to turn this over to Luis Ostrowski-Zeitner, President-elect of the MSG ERC and at UT Houston.
We're in the final lap here. We have two very interesting posters to highlight today. The first one is particularly important to me. This is one of our former fellows here at UT, currently an assistant professor at the University of Arizona in Tucson, and Dr. Al-Obaidi is going to feature a case of Coccidioidomycoses in a patient with COVID-19.
Hi, thank you for inviting me. And thank you, Dr. Ostrowski, for inviting me here. So let me figure out how to share my screen. Okay. Are you able to see my screen?
Yes.
Yes, we can move.
Okay. Hi. So first of all, thanks again for inviting me. And here I'm presenting a case about pulmonary coccidioidomycosis in kidney transplant patient with COVID-19. I'm Mohammed Al-Obaidi. I'm a clinical assistant professor at University of Arizona and transplant ID physician in Banner University Medical Center. Here's my disclosure, nothing pertinent for this presentation otherwise. But a little bit background here. First, as we discussed earlier in this conference, patients with COVID-19 infection are at increased risk for invasive fungal infection. Several examples given during this today's talk. And recently, actually within last year, there were several cases of coccidioidomycosis associated with COVID-19 infection being reported. Here, I'm presenting a case of immunocompromised host, unlike the last cases being reported in the literature. And especially here is important because COVID-19 and immunocompromised host to increase risk for fungal complication, and coccidioidomycosis especially has a high risk for complication. So timely diagnosis is critical. So I will go over the case. This is a 33-year-old diabetic man with post-disease donor kidney transplant, presented with acute hypoxic respiratory failure and was diagnosed with COVID-19 pneumonia. Main symptoms were of COVID-19, cough and shortness of breath, and you can see he had hypoxemia with white cell count was low with lymphocytopenia, and had acute kidney injury. Immunosuppression was included induction with antithymocyte and maintenance therapy with mycophenolate, tacrolimus, and prednisone. However, the mycophenolate was switched to everolimus shortly before the presentation and was stopped because of COVID-19. And his home post-transplant antimicrobial prophylaxis included valacyclovir, ativoquan, and fluconazole. And our institute, we use fluconazole for coccidioidomycosis post-transplant prophylaxis for at least 12 months. His pre-transplant coccidioidomycosis serology and history did not include any positive like serology or history of cocci. And so as the donor, who was originally from Arizona, did not have documented coccidioidomycosis or serology. So during this hospitalization, during his COVID-19 hospitalization, he had to readmitted 3 times. So the first time he was treated with remdesivir and dexamethasone shortly and was discharged on his home antifungal therapy. And however, in 10 days, he was readmitted and he was having worsening shortness of breath. And you can see his CT chest here showing a worsening of his pneumonia, although we don't have a baseline one from previous admission. And he was treated with isobutanol and more steroids and antimicrobial. However, he had some improvement of symptoms and he was discharged. Unfortunately, in 3 days after discharge, he was readmitted again and required intubation. And that time, which is day 37 from initial diagnosis, he had a bronchial alveolar lavage, which was negative for fungus culture, so was galactomannan. Despite that, he was on isobutanol, restarted from fluconazole at home. And you can see his CT chest is significantly worse. His serum beta-D-glucan and Coccidioidomycoses serology, which is commercial test, were negative on several occasions, and the last one was on day 59. On day 46, he has a tracheal aspirate, which sent for fungus culture, and so was on day 61. It took 2 weeks for it to grow and showed Coccidioides species. And on day 62, Coccidioides antibody was sent to another lab, Mira Vista laboratory, which showed that it was very positive, despite the commercial test that we use in-house was negative. During that time, he was completely on isobutanol only, and we were interested to check the level, and it came back of 0.7 microgram per ml. Therefore, when we have a new diagnosis of coccidioidomycosis, we started him on liposomal amphotericin B, and we switched his isobutanol to voriconazole with therapeutic drug monitoring to keep a level at least of 1, because the patient had issues with transaminitis. And we have to increase the dose from 200 milligram twice a day to 250 milligram twice a day. However, because of complexity of the patient, we continued liposomal amphotericin B for 60 days. He continued to improve, and he was discharged after 2 months from the hospital. And he was on initial tracheostomy and on supplement oxygen. On day 170, he slowly recovered, and he's off oxygen, and the tracheostomy was removed. He was switched to fluconazole because of continuous issues with transaminitis and voriconazole. And on day 239, after COVID, he repeated cocci serology. IgM was positive, but that's a commercial test, and IgG continued to be negative, and patient continued to feel great. So here I just wanted to discuss a few cases being reported in the literature resemble our case, but they're all immunocompetent patient. As Dr. Thompson, G.R. Thompson, showed in this case, which is the first one, is 23-year-old male, Navy, African-American male, who had COVID-19 in San Joaquin Valley, California. And after that, he moved to Guam, and after 30 days, he developed disseminated infection. Main risk factor was being African-American race, but no history of immunosuppression. But the patient was reported to be alive, and he received adequate treatment. The other patient was a 67-year-old from southwestern USA, and also had COVID-19, and but did not receive any immunosuppression or hospitalized, and was shown to have pulmonary nodules and chest wall lesions, which showed to be positive for coccidioidomycosis. Same thing, the patient was patient was diagnosed and received fluconazole and reported to be alive. The third case in the literature was published from West Texas, actually, about patient with severe COVID-19 was with uncontrolled diabetes, required high-dose steroids. Unfortunately, the patient continued to worsen, and the last few days of his life was diagnosed with Coccidioidomycoses postedacii. However, there is no mention about treatment because of delay in diagnosis. And the fourth case was a 65-year-old guy from Mexico was admitted in hospital in Los Angeles with also severe COVID-19. And he was mainly being worked up for tuberculosis, and seems to be at some point, finally the team found that he had pulmonary coccidioidomycoses after he developed skin lesions. And liposomal amphotericin B was later on started. However, the patient was reported to be deceased. And the last two cases are a little bit different. Well, fifth case was 48-year-old Hispanic female from Bakersfield who treated for COVID-19 and found to have multiple nodules during her hospitalization. And main risk factor steroids. And patient was diagnosed early and was treated, and according to the report, was reported to be alive. And the last patient, as shown in earlier in our the talks, this is a patient, actually, he had history of coccidioidomycosis, and he's from Kern County and was not on treatment. But after COVID-19, they noticed that his pulmonary nodules started cavitating and get worsened. However, there's no report about him being treated, even with that progression, and patient was reported to be alive. So overall, all these cases mentioned of immunocompetent patient with COVID-19, some of them are after COVID-19 or as a co-infection presentation. And the main issue here we have, even in Arizona, like the time to diagnosis is very important. For coccidioidomycosis serology test, most of the time we have lower sensitivity, especially in the early course of the disease. But in immunocompromised host, we tend to have like sometimes patient with delayed antibody production. Miravista antigen or galactomannan antigen and beta-D-glucan were helpful in severe cases and cases of disseminated disease. However, they are not helpful for localized infection. Also, we showed that combination of these testing, and as we showed in our previous ID week presentation, that we can increase the yield and sensitivity of the test. And recently, Miravista developed coccidioidomycosis enzyme immunoassay antibody test showed to have higher sensitivity, mainly in the immunocompetent patient, possibly in the immunocompromised patient, as shown here in our case. So coccidioidomycosis should be, an immunocompromised host should have a proper antifungal therapy be started as soon as possible. And this is based on epidemiology and risk factors. Mainly the treatment for coccidioidomycosis is azole therapy and liposomal amphotericin B. And with azole therapy, it's recommended to check levels. Although high fluconazole was shown to have activity against coccidioidomycosis in previous studies, it's still not known what's the proper therapeutic drug monitoring, or what's if there's any guidelines about monitoring fluconazole drug level. So overall, in conclusion, in cases of patients who present with COVID-19 or immunocompromised patient with COVID-19 in general, we should suspect coccidioidomycosis whenever the epidemiology fit. And we should think about treating the patient early on in the presentation. In the immunosuppressed patient, the serological test can be of low yield and vary between assays. And if it's suspected, we need to start treatment as soon as possible. And here we presented a case of possible isobutanol breakthrough coccidioidomycosis, and it's unknown if the isobutanol therapeutic drug level is the cause, or the immunosuppressed host, a high immunosuppression case, or it's related to other factors. And I would like to thank you all for listening to my presentation, and here are some of my references. And if you have any questions, let me know. Thank you.
Thank you very much, Dr. Al-Obaidi. Very interesting case, which clearly underscores the diagnostic issues we still have with Cocci, even with serologic diagnostics, and of course, pitfalls with drug monitoring and breakthrough infections. To finish off the day, it is my pleasure to introduce Dr. Carla Roman-Montes from Instituto Nacional de Ciencias Médicas y Nutrición Salvador Subirán, which is the flagship hospital for Mexican NIH. And Dr. Roman-Montes is an attending in infectious diseases who also works in the microbiology laboratory and is doing a master's currently in medical science. Dr. Roman-Montes will be presenting their experience in invasive fungal infections in critically ill patients in Mexico City.
Thank you, Doctor. Hello, everyone. I am Carla Roman from Mexico City, and I'm going to talk to you about our work that is titled Invasive Fungal Infections in Critical Ill Patients with COVID-19 in Mexico City. Thank you for the opportunity. First, I want to tell you about our center. The Instituto Nacional de Ciencias Médicas y Nutrición Salvador Subirán is a tertiary care center in Mexico City that had 160 patient beds in wards, 14 intensive care units, and only 8 intermediate care unit beds. In March 2020, the Institute conversion into a COVID-19 center. For this, increased to 15 intensive care unit beds, handled by non-critical care physicians and nursing, and in areas that not designed for critical patients. Until October 2021, more than 3,000 hospitalizations and more than 10,000 ambulatory care COVID patients was admitted. Well, as we have seen in all the day, the spectrum of COVID-19 associated fungal infections is big and faces a diagnostics and challenge and diagnosis and treatment challenge. And we know that the fungals that are more frequent involved in fungal infections are Aspergillus, Candida, and Mucormycosis. For this, our objective was to describe incidence, prevalence, clinical and microbiological characteristics and outcome of critical ill COVID-19 patients with invasive fungal infections. Well, about methods, we conducted a retrospective study. We revised all patients that admitted to any critical unit between March 2020 to April 2021. We revised demographical, clinical, and microbiological data from the electronic medical report. And we include all patients who develop an invasive fungal infection during hospital stay. We consider these criteria for invasive fungal infections, and we matched age and sex controls who did not develop fungal infection, who compared with characteristics. We report an outcomes, especially hospital mortality, intensive care unit stay length, and hospital length stay. The protocol was approved by Ethics and Research Committee. Well, I showed you our results. We found an 8% patients who developed fungal infections during ICU stay. We showed you that most were male. The mean age was 57 years, and the most than 50% was obesity, and the comorbidities are more frequent were diabetes type 2 and hypertension. As you can see, no basal difference were seen. Fungal infections, the most frequent fungal infection was Kappa. with more than 15%, followed of invasive candidiasis with almost 36%, being the most common candidemia. And we have 3 cases of mucormycosis and 3 cases of pulmonary cryptococcosis. The days from ICU admission to invasive fungal infections was 9 days, a median of 9 days. And 85% receive antifungal. Well, about outcomes of these patients, we found an important difference between patients with invasive fungal infections and versus non-invasive fungal infections in hospital stay length and intensive care unit stay in median days and duration on ventilator median days. All were longer in patients with invasive fungal infections when compared with patients that not have invasive fungal infections with a statistical significance. About COVID-19 associated pulmonary aspergillosis, Kappa, we have 78% of possible Kappa cases and only 22% of probable Kappa cases with AMM-ISHAM criteria, but all met as ICU criteria for putative pulmonary aspergillosis. We have 33 positive aspergillosis cultures, 31 from tracheal aspirates, and only 2 from bronchoalveolar lavage. And Aspergillus fumigatus was the most frequent species isolate, and none with azole resistance by microdilution. Well, we have 8 cases, 22% with a had positive serum galactomannan antigen. About 97% with tomography for Kappa diagnosis. The most findings were 57 with ground glass infiltrates progression, 11 with micronodules, 5% with consolidations, and only 1 case with a cavitation. 81% received antifungal treatment, was voriconazole the most frequent in 93%, and we found an 59% hospital immortality rate versus 33% than other IFI, or 47% without invasive fungal infections. That is important because this percentage is greater than other groups. About COVID-19 associated candidiasis, we found 22 candidemias and 2 proven pulmonary pleural infections. The most frequent species was Candida parapsilosis in 15%, followed by Candida albicans and Candida glabrata. 79% had a prone position during intensive care unit stay, and 100% with venous catheter central with 30 median days from placement to candidemia, and none had total parenteral nutrition. None of these cases with persistent candidemia. 25% have an ophthalmological evaluation during the candidiasis, and 8% have an abnormal finding, is endophthalmitis, and 61% had an echocardiogram, one of these with endocarditis data. 100% of Candida parapsilosis were fluconazole resistant, and I want to show you our historic distribution of Candida species that were Candida albicans, followed tropicalis and glabrata, the most species that we are isolate. And previously, only 6% of Candida parapsilosis were fluconazole resistant. For this, now a clonately study is pending, where here 96% receive antifungal treatment, 86% with receive echinocandin, and 40% anazole. 29% mortality was registered versus 1470% versus, of patients with non-invasive fungal infection. Well, in this graph, I want to show you a bi-monthly rate of invasive fungal infections per 1,000 intensive care unit admissions. And first, in the timeline, the X line, we can see the time when dexamethasone starts as a standard of care. And we can look 2 times of Candida or Candidemia outbreaks and two times of Kappa outbreaks. Well, what was concluded and done after this finding in our hospital about candidemias, infection control strategies, a critical care personnel education start, and safe intravenous lines management, and double glove eradication and high hygiene. About Aspergillosis, we suspended particulates measurement and revision and replacement of ventilation filters on reconverted critical areas. About COVID-associated mucormycosis, we have only 3 cases, 2 pulmonary and 1 rhinosinusal. 2 were male and only female. 2 had obesity and 2 had diabetes, 2-type diabetes. The diagnoses were with culture in 2 cases, and in 1 case, a positive PCR Mucormycosis was positive. 3 cases received treatment with antifungals, and only case stay alive. Well, finally, we made a mortality analysis in which I can show you the possible factors associated with the mortality. And we found after a multivariate analysis that those who died were more probable male, older, and the most had Kappa, and less frequently receive antifungal management. With this, we conclude that invasive fungal infections occurred in 8% of critical ill COVID-19 patients. Kappa was the most frequent, mostly diagnosed through tracheal aspirated culture. Only 22% had a positive serum galactomannan. We faced to limited availability of bronchoscopies because of aerosol generating procedures concern, and several arts precluding the procedure. And for this, we are on an ongoing study to compare tracheal aspirates galactomannan versus bronchoalveolar galactomannan to measure the accuracy. And one thing important is that infection control practices reinforced during outbreaks, especially frequent revision on maintenance of ventilation system, and catheter-related candidemia outbreaks due to the gaps in infection control. Important is a central line bundle reinforced, double glove practice, and hand hygiene reinforcement. Novel strain of fluconazole-resistant Candida parapsilosis involved in the most cases, and a single case of rhinosinusal mucormycosis in a patient with diabetes and steroid treatment. Despite an elevated prevalence of uncontrolled type 2 diabetes and unregulated steroid use in Mexico, warrants high suspicion of this invasive fungal infection. Well, increased mortality was seen in older patients with Kappa who did not receive treatment. For this, increased awareness and early diagnosis and treatment of patients with Kappa may impact on mortality, and invasive fungal infections remain a challenge, especially in the context of a collapsed healthcare systems. Well, I want to thank the whole team, but especially to my chief and mentor, Dr. Fernanda Gonzalez, and all the people who work with us. Thank you, everyone.
Thank you very much, Dr. Roman-Montes. Very interesting work showing basically the epidemiology of IFIs in high complexity reference center in Mexico. And this really underscores how we need to work together and cross borders to create some of this data. I have a quick reminder for those of you that are not monitoring the chat. We are going to be sending a survey after the meeting, and we need to hear your input for planning future meetings. And I'm going to turn it over to our convener, Dr. Pappas, to close out the session.
Okay, thank you, Luis. And thanks to all the presenters who took their time to participate in this webinar and share their information. That was an outstanding session. For a lot of new data and learned a lot. I'm sorry we didn't have more time for questions. I suppose what I can suggest is that for those who have unanswered questions, to submit them, and we will disseminate them to the speakers, the appropriate speaker, who then can answer those questions directly, or they'll answer them through me. But in any event, I apologize for not having more time. We just ran a little over, but it's approaching 3:30 now, and so I think we'll convene this seminar. I want to thank everybody from MSG ERC. I'd really like to thank Castle and Associates who organized this call, the CDC for their sponsorship and helping us to do a lot of these educational programs, Tom Chiller especially, but all of those in the Mycotics branch. I'd like to also thank Lisa at Terra Nova and the work that they've done in being an educational partner with us. So with that, I'll end the meeting and thank everyone for participating. We had a great turnout. And again, submit your questions and we will try to get them answered as expeditiously as possible. Okay, thank you again. Have a great day and a great week.